three people examining people.
Good evening, respected professor and my dear students. I welcome you all to the second session of practical examination topics under RESA DNB online academic activities in this WebEx platform. Without wasting much of your time, I hand over the session to students and professor. Over to professor and students. Thank you.
Thank you very much. Hopefully this is the last class for this exam going back. Wish you all good luck. I will just go ahead with the presentation on the questions. First, we will start with BLS and the ACLS because we have not discussed that all these classes so far. Is it okay?
Yes, sir.
Yes, sir.
Is screen visible?
Yes, sir.
Yes, sir.
So we will start with BLS first, basic life support.
Sir, we are unable to hear you, sir.
No, the screen is not moving. I don't know why. My mouse is giving trouble. Are you able to hear me?
Yes, sir.
Yes, sir. We are able to.
So this is the first question. What is the correct order of steps in the in-hospital chain of survival for adults? You can try to answer that.
So, first
Activation of emergency
Yeah,
response.
early
Early
recognition and prevention.
One at a time and with a little
Early
clarity.
recognition and prevention,
Hmm.
activation of emergency response,
Hmm.
high quality CPR,
Hmm.
then followed by defib, followed by post cardiac arrest care and recovery.
Whatever. Okay. So early recognition, activation of emergency responses, high quality CPR, defibrillation, post cardiac arrest care, and recovery. Okay. Right. What can be done to avoid delay in starting CPR?
Assess breathing and pulse within 10 seconds.
Good. Assess breathing and pulse at the same time within 10 seconds so that you can avoid delay. What is gasping a sign of? You say gasping breaths, no?
Ongoing arrest.
Cardiac arrest. Yes, it's a gasping is a sign of cardiac arrest. Which pulse to be checked in cardiac arrest?
Carotid pulse.
Carotid pulse.
Carotid pulse. Very good. What is the correct chest compression rate for adults?
30 to 1.
100 to 120 minutes. Okay, chest compression individually. What do the feedback devices monitor during CPR?
Metronome.
Huh?
Metronome device, sir.
Pardon?
Metronome.
CPR
No.
quality. It
Feedback devices.
It will assess the quality of CPR and how much depth.
Compression
Compression.
rate as well as compression. Okay? This is called the feedback monitor. So when you use this is how the compression is given over that monitor. Okay? You don't give it directly on the chest, and it will assess the compression depth, compression rate, and chest recoil also will be assessed by this. How to open the airway by a single rescuer?
Jaw thrust, head tilt, chin lift. Chin lift,
Yes.
jaw thrust.
Yes, by head tilt and chin lift. This is how you do that. You put your hand on the forehead and then try to. What is the contraindication for this head tilt?
Cervical
Cervical spine
instability.
Cervical
injury.
spine injury. Very good.
Instability.
What is the position of the rescuer while using pocket mask for ventilation?
Side of the
Side of the patient. Very good. So this is the pocket mask that we use. What are the advantages of the bag mask ventilation? What advantages and disadvantages?
it will give rescue breathing.
Hmm.
And with
Can you supplement oxygen with bag mask ventilation?
yes, sir.
Yes, sir.
That is also possible, isn't it? That's one of the advantage. You can attach an oxygen supply to the rear of the bag mask, then give extra oxygen. But what is the disadvantage?
Gastric
Gastric
insufflation.
insufflation.
Gastric distension. You do not know how much pressure you are causing. Okay, sometimes in a weak lung you can cause a barotrauma also. The advantage: provide positive pressure, give additional oxygen by attaching oxygen supply. Disadvantages: mask leak, gastric insufflation, and sometimes barotrauma also. What are the steps in the use of bag mask ventilation during CPR?
Head tilt, chin lift, adequate mask,
Position.
seal.
Position. Oh.
First, to open the airway nicely, and then select the correct size mask. Place the mask over the face without leak. Okay, using the bridge of the nose as the guide. Second step is use E-clamp technique to hold the mask in place. What is E-clamp technique?
The mask is the three fingers of little finger and fourth finger, third finger. Sir, C is around the mask.
So all the three fingers go below the jaw. Okay, that E is formed by the lateral medial three fingers, little, middle, ring, and the middle, and they will form the lifting of the jaw and squeeze the back to give. So this is how you hold it. No, this forms a C and this forms the E. So all the three fingers they form like a alphabet E, and this is how you hold it. If you are a single rescuer, this is the method to do that. If you are a double rescuer, one can hold the mask in obese patients. A single person can hold using both hands for a tight fit, and the other person can squeeze the back. So how does an AED help during CPR? What is the expansion for AED?
Automated external defibrillator.
Automated electrical defibrillator. Okay. So what does it do?
Analyze the
Why in
rhythm and
BLS
give shock.
AED is a very important machine?
Analyzing
To
the
analyze
rhythm
heart rhythm
and
and
give shock.
provide shock for defibrillation or cardioversion depending upon the rhythm that is analyzed. And what are the two life-threatening arrhythmias and their nature?
Ventricular fibrillation.
Ventricular fibrillation and
Pulseless
pulseless
tachycardia.
Pulseless
ventricular
VT. Very
tachycardia.
good. Pulseless ventricular tachycardia and ventricular fibrillation. Both are shockable. Their nature is both are shockable rhythms. After an AED delivers a shock, what should the rescuer do next?
Resume chest compressions.
Resume CPR. Very good. Resume chest compression. What are the steps in the use of AED?
We should power
on.
and we should attach for lateral position and we should connect the charging and we should stop the CPR. After that, it will analyze the rhythm. That 10 to 10 seconds, we have to start the CPR. After it will give the current shock. That time we have to clear the AED and the shock will deliver. Then continue the CPR.
So complete the check and call steps. Then second is AED is turned on to charge and follow the voice prompts. Sometimes the AED has audio also. It will by itself give all the instructions. So follow the voice prompts. Remove all clothing covering the chest of the patient. If necessary, wipe the chest dry. Place one pad on the upper right side of the chest and the other on the lower left side below the nipple. So this is the anterior placement. Suppose there is a contraindication for that, you keep it antero-posterior also. You can keep it one on the front and one on the back. Prepare to let the AED analyze the heart's rhythm. Deliver a shock if the AED determines one is needed. And before that, make sure no one is touching the person. Say clear is in a loud and commanding voice and push the shock button to deliver the shock. This is a very, very important step so that those who are involved in the CPR should not get a shock. So that is a very important step. After the AED delivers the shock, if no shock is advised, immediately start CPR, beginning with compressions. What to do following the scenario? In the following scenario, it is patient unconscious but pulse felt and patient is breathing. Patient is unresponsive, but you are able to palpate a pulse. But patient is also breathing.
3 years to the patient and
Airway
again see the
breathing
monitor
circulations.
vitals.
Should
COPD,
access airway breathing circulations.
No, again,
monitor until emergency responders arrive. Because here there is a pulse, there is breathing. But only thing patient is not conscious. So keep monitoring the pulse, whether it is regularly being felt, whether the patient is breathing adequately. Monitor that two vital functions until emergency responder arrives. The next scenario is no normal breathing, but there is a pulse felt and patient is not responsive.
give rescue breathing.
Bag and mask. Rescue
Give
breaths.
one breath every 6
six
seconds.
seconds.
Monitor pulse. If absent, start CPR. Very good. No breathing, but gasping and no pulse.
Start CPR.
Start CPR.
Start CPR.
Start
And rescue.
CPR at the rate of 30:2 for 2 minutes. Attach AED. If shockable, give shock. Resume CPR. Check rhythm after 2 minutes. All these steps have to be written. Okay. So this is the situation where CPR is indicated. No breathing, no pulse, and patient is gasping and unresponsive. So you must say the number of compressions to ventilation also and duration. Just starting saying that start CPR is not enough. Then attach, the next step is to attach AED as you are doing this, and if shockable, do early defibrillation. Which team role make decisions and assign roles? Who is the person
Team
in
leader?
the team?
Team
Team
leader.
leader. Very good.
Team leader.
Yes, team leader is the person. Effective team dynamics consists of what are the components of effective team? That is the performance of the team to be effective and useful. What are the components?
Closed loop communication.
Knowing their limit.
So debriefing, knowledge sharing, constructive intervention, clear roles and responsibilities. Okay? These are all called the team dynamics. That is debrief. What do you mean by debriefing?
After the resuscitation attempt, discuss whatever happened and how it could be improved.
Very good. So it is something like an audit. After you have completed your task, you go ahead and find out what you have done is right or wrong by discussing it. Whereas if you just say briefing, it is like instructions before you start CPR. So debriefing is analysis of your performance, how you do that. And if there are any plus or minus, you share that so that you don't make that mistake again. Then during CPR, there should be no adverse comments or criticism. It should always be a constructive intervention. And the roles of each person in the team should be clearly assigned, and there should be no confusion on that. Okay? How to achieve maximum chest compression fraction?
Minimize interruptions.
Minimizing interruptions.
Excellent, excellent. By minimum passes during chest compression. Okay. How to avoid fatigue during two rescuer CPR? If two persons are doing the CPR maneuver, how to avoid the persons?
Every 2 minutes.
Vocalize, sir,
Exchange.
when the person's tired and exchange every 2 minutes.
Every 2 minutes they have
Every
to
2
change
minutes
the
exchange
That's
the
the
roles.
time interval. Shift the rescuer every 5 cycles or 2 minutes. So that's how you avoid the person getting fatigued by the strenuous person of the doing chest compression. What is closed loop communication during CPR?
Giving an order and then reconfirming what was said.
The process of verifying the message and was received as intended. Okay, that is whatever the way you described it is also correct, but this description is more apt. The process of verifying that the message sent was received as intended. For example, if you say load adrenaline to your assistant in the team, then that person should reply back saying that adrenaline loaded and ready. Then only you know that what you wanted to say to that person has been understood by that person also. Okay? That is called closed loop communication. What is constructive intervention during CPR?
The CPR
components-
coach gives feedback, sir, about the depth and if the rate is adequate, and the leader has to confirm the
Correct
different
actions
steps.
when which are incorrect in a tactful way. Okay. So even if you are a person who is doing the chest compression, is not giving adequate chest compression or time for recoil, you should not scold him or say you are doing it wrong like that. That no comment should be like that. It should be told in a tactful way without hurting him as well as not exposing his incorrectness to the other team members. So correcting actions which are incorrect in a tactful way is called constructive intervention. Who formed the resuscitation triangle in a high performance CPR team? Who means it is not the person, it may be something else also. I don't think it should be the persons involved in it. The technique, it can be instrument.
Defib, compressor, and airway.
Airway, okay, airway, AED monitor, and compressor. Okay, these are the three things which form the resuscitation triangle. How many rescue breaths will be given to an adult and a child? Is there any difference?
Yes, sir. In adult 30:2, sir. In
Is it for single rescuer or double rescuer? Two rescuers. Rescue breaths means now we are not talking about compression here. We are talking about only the number of breaths per minute.
Two
In adults,
rescuers.
usually 10 breaths per minute. Okay, that is every 6 seconds. In a child, it is every 2 to 3 seconds. That will be about 15 to 30. How CPR performed differently when advanced airway is present. Like is there any change in the compression ventilation ratio?
Continuous compression of 100 to 120 per minute without any interruption for the breaths.
Excellent. Okay, when the advanced airway is no pass for ventilation is required at all. So you can continue ventilation because advanced airway is there and you can do it with an ambu bag, and the person doing the chest compression can continue at the rate of 100 to 120 if it's an adult. How is the compression and ventilation done differently in the presence of advanced airway? It's the answer I already given. So compression 100 to 120, that's every 6 seconds for adult. and 2 to 3 seconds per second, no interruptions for ventilation. Which devices are considered advanced airway devices?
Laryngeal mask airway. And
after
endotracheal
ROC
tube.
obtained, we do the ET tube.
ET tube, yeah. Supraglottic airways and ET tube both are considered as advanced airway devices. What are the routes of administration of naloxone in case there is an opioid overdose and you want to give naloxone?
IV,
What
IM,
all the
IV, IM,
and intratracheal tube.
IV, IM, then I am not hearing the other one.
Intranasal.
Intranasal and intranasal also can be given. How to apply AED pads in a patient with pacemaker or ICD?
over the pacemaker.
No, sir. Conjunctal.
Little away from the pacemaker.
Far away from that, as far as possible. Okay, well away from that. Apply the pads well away from the pacemaker or ICD. How is CPR done in a pregnant patient?
One rescuer do left uterine displacement, sir. One person's
If there are 2 persons, but if it is a single person,
left lateral position or
very good, excellent. So 2 rescuers, one can do chest compression and second to do lateral displacement of the gravid uterus. But if it is a one rescuer, give left lateral tilt and start chest compression. Okay. So this is how the two persons here. Actually, there are 3 persons. So one has already put in the advanced airway and doing the ventilation. The other one is doing the compression, and the third person is giving the left lateral tilt right, pushing the gravid uterus. What are the 5 priorities in both adult and pediatric BLS?
high quality CPR.
So verify
scene
safety, check for responsiveness, get bystander help without leaving the patient, activate emergency response, get the AED by another person. But the person starting CPR should not go to get the AED and fix it. So scene safety is very, very important. That is the first step. Check for responsiveness of the patient, get bystander help also, activate emergency response, get the AED. During CPR in pediatric patients, what is the cycle of compression to rescue breathing with one rescuer and 2 rescuers?
With one rescuer, 30
30
is to 2.
2 rescuer,
15 is to 2.
Okay. Very good. The AED determines a shockable rhythm. What is the BLS step required?
Stop CPR and give shock.
Give one shock and resume CPR 2 minutes. Continue this till the arrival of emergency medical service or advanced life support team. That is the recommended by BLS. What is the recommended BLS sequence for the 2020 International Liaison Committee on the Resuscitation Guidelines?
verify scene safety, check for responsiveness. If no
That is
breathing,
already what you have, the same thing you are repeating. Chest compressions, airway and breathing. Okay. That is ABC was the earlier one, but from 2020 it has become compression is the priority. CAB has become, ABC has become CAB now. That is the answer that is expected. Which set of procedures summarize what CPR is? Okay, the answer is A, chest compressions and rescue breaths. B, mouth-to-mouth respiration and chest massage. C, chest compressions, opening up airway and rescue breath, all of the above. So these are the 4 choices. A, B, C, D. What is your option for this question? What set of procedures summarize what CPR is?
C.
C.
C. Yeah, chest compressions, opening airway, and rescue breath. Okay, so the answer is only C. What are the modifications in BLS 2020 guidelines? That has been the question sometimes asked. So the content contained herein is based on the most recent recommendation. So first, what is the recommendation for adult basic life support for CPR?
Compressions should be
Hmm.
given first preference.
The importance of early initiation of CPR by lay rescuers has been re-emphasized. Okay? So these are recommendations to improve the quality of BLS. So even anybody who is around and who has recognized a cardiac arrest should be able to initiate. That is why it's COLS or compression only life support is
Yes,
being
sir.
popularized by teaching it to the common public also. Okay? So the importance of early intervention by lay rescuer has been re-emphasized. The risk of harm to the patient is low when you start CPR. You are not going to do further harm. In fact, it may, even if the patient is not in cardiac arrest, you are not going to cause any harm. That is the reason why compression only rescue is being recommended now. And bystanders should not be afraid to start CPR, even if they are not sure whether the victim is breathing or in cardiac arrest. So the whole thing indicates that whoever knows to do CPR, even if they are a bystander, they should start. That is the first recommendation. Sorry. What is the new link added to the chain of survival in 2020 guidelines?
Recovery, sir.
Recovery. Earlier it was only 5. Okay, these are the 5 things. Call for help, compression, defibrillation, transportation, and advanced care, and defibrillation after the admission. So a 6th link called recovery was added to the chain of survival. So what was earlier is now become the 5 links has become 6 links. What is the care to be provided after return of spontaneous circulation?
Post cardiac arrest algorithm.
What are the things that comprises of?
Airway, definitive airway to be secured with the ET tube. Airway breathing circulation to be maintained. Breathing saturation to be more than maintained between 92 and 98%, and circulation systolic should be more than 90, and diastolic should be more than 60. And after that, if the patient is unresponsive, targeted temperature management should be maintained at with 32 to 36 degrees Celsius, and expert consultations should be done.
Okay. But the answer given here is care of the patient after return of request, close attention. So first is oxygenation, second is blood pressure control, third is evaluation of percutaneous coronary intervention, targeted temperature management, multimodal neuroprognostication. Okay? So these are all the things as per the guidelines. These are the terms that are given. What 3 functions need assessment and support during post-cardiac arrest recovery period?
Neurological functions.
Yes, that is one. Among the 3 is also neurological recovery.
Cardiac
Okay.
and
Because recovery from cardiac arrest continues long after the initial hospitalization, we must give support for physical, cognitive, and psychosocial needs. So these are the 3 terminologies that are used in the guidelines. Who should have post-resuscitation debriefing? How does it help? I already told you what is, we discussed what is debriefing. That is analyzing your acts and seeing whether everything has been done correctly or any mistakes have been committed, and in future how to correct it. It will idea of doing debriefing. So who are the persons who require this debriefing session, and what do you achieve by doing it?
Resuscitation team to
Entire
improve
team?
further
Team leader.
outcome.
Okay. After resuscitation, debriefing for lay rescuers. Supposing it is done by a bystander, they also should be taught whether what they have done. When if you have observed him doing a CPR or a chest compression, and if he has not done it correctly, you can tell them how to do it correctly. Or if he has done it correctly, you can appreciate that you have learned the technique correctly and you are doing it well. And you should debrief to the emergency medical service providers and also hospital-based healthcare workers. Okay, it all comes to public as well as paramedic persons. And when you do that, it will be beneficial for their mental health and well-being. That is, when you appreciate them, they feel satisfied that they have done a good job, and that will help their involvement to be more sincere and more committed. Okay. What is the guideline in the management of cardiac arrest in pregnancy according to this 2020 guidelines? Right. Here the importance is given for perimortem cesarean delivery. Okay. Management of cardiac arrest in pregnancy focuses on maternal resuscitation with preparation for early perimortem cesarean delivery if necessary to save the infant, and if not, improve the chances of successful resuscitation of the mother, so that the compression by the gravid uterus is taken off. Venous return will be much better because the IVC compression is removed, and the chances of maternal resuscitation and the success of CPR in the mother is very high. Okay. So early perimortem cesarean delivery is to be considered. That is the guideline. Right. So that finishes the questions on BLS. Now there are some questions on ACLS also. Okay. A 48-year-old male brought to the ER in an unresponsive condition with no pulse, no respiration. What is to be done?
Start CPR, sir.
Start CPR. Answer is correct. Start chest compression at 100 per minute. Rate also should be mentioned.
Yes,
Okay.
sir.
A 57-year-old male complains of chest pain. BP is 92 by 50. Heart rate is 92 per minute. Respiration is 14. Oxygen saturation 97%. What to do?
Obtain 12 DCG
12
and the
DCG
cardiac
and-
markers.
Fantastic. Okay. 12 EKG to rule out ischemia. Person brought in an unresponsive state with no pulse, connected to AED, which is not working. What to do?
Start CPR.
Start CPR.
Start CPR straight away without waiting for any other electrocardiogram. Person who suffered cardiac arrest is given CPR for 2 minutes, and his EKG shows this with, that is I am going to show the picture, this with no pulse. IV access secured. What to do next? Okay, this is the ECG tracing that has been achieved.
IV adrenaline 1 mg.
Epinephrine 1 mg.
What is the diagnosis of this EKG?
Pulseless electrical.
Pulseless electrical activity.
Pulseless electrical activity. It is showing electrical activity with no pulse. Very good. So give 1 milligram ephedrine IV and continue CPR. Excellent. What is the common but fatal mistake that can happen in cardiac arrest management?
Giving shock to the non-shockable rhythm, sir.
Prolonged interruption in chest compression. Okay? That is the common mistake that can be done, and that can be quite fatal. So at no cost you should interrupt the chest compression. So it should go on continuously. What is the important component of high quality CPR?
Push hard, push fast,
Test.
and many.
Huh?
Push hard and
Hard and
fast
push
with the
fast.
compression of 100 to 120 per minute. Chest recoil allow for adequate chest recoil at least 2
recoil.
inches.
That is the most complete recoil of the chest. Why complete recoil should be allowed?
For the heart to fill
with blood. Okay, then only venous return will happen. Okay, very good. What increases the success of cardioversion of ventricular fibrillation?
Immediate defibrillation.
Which defibrillation will get reverted faster, or force or fine fibrillation?
Fine.
Course.
Force. One say force, one say
Right.
fine. Okay. Quality compressions is very important. That helps in the conversion of VFib. But I'll tell you about the types of VFib in a later discussion. So quality compression is very, very important before you resort to defibrillation. What is the best description of pulseless electrical activity?
That is electrical activity, but no mechanical
Palpable
pulse.
pulse. Okay. So sinus rhythm in EKG without a palpable pulse. Without this. What is the best method of performing high quality CPR with an advanced airway in place?
No pulse ventilation.
continuous CPR for 2 minutes, 100 to 120.
Continuous chest compression without pause and 10 assisted breaths per minute. Okay, that is the best method. What does EtCO2 of 8 mm mean after CPR?
Improve the high.
Poor quality of the chest compression.
Poor quality, very good. CPR is not enough effective. Minimum should be 10 millimeter. Fantastic. What is an important safe practice during defibrillation?
Clear, all persons should be clear from the
Oxygen should not blow over patient's chest during shock. That is very, very important. If you are giving supplemental oxygen with a mask, this may cause an electrical fire. Okay? And what is the advantage of hands-free defib pads over manual defibrillation paddles? Now, what is hands-free defib pads? Which are stuck to the chest. Whereas the paddles are held by the rescuer and then applied to the chest. So what is the advantage of that hands-free? Which will have a better contact?
hands-free.
Hands-free, yeah. So hands-free offer more rapid defibrillation because they are in constant contact with the chest compared to your manual. You may not press it so well. So which actions is included in BLS survey in the management of cardiac arrest? Early defibrillation, included in the BLS survey to find out which cardiac arrests are revived early. What is the drug of choice and its dose in refractory ventricular fibrillation? Supposing you have been giving defibrillation repeatedly and the heart is not responding. So which drug you can give to find whether it will get reverted back to sinus? Amiodarone, 300 milligram IV can be given to find out in refractory VFib. What is the maximum time in interruption during chest compressions?
10 seconds.
Less than 10 seconds.
Less than 10 seconds. Very good. What is the purpose of medical emergency team or rapid response team? Right. Improvement in patient outcome after resuscitation. That is done by the medical emergency team who rush to the spot. What is the ventilation strategy in adults with respiratory arrest and the heart rate of 80 beats per minute?
10 breath per minute.
It is 1 breath every 5 to 6. That is 10 breaths per minute.
10 breaths
Same
per
thing. Constant. That is a constant. Okay. 60 years male with complaints of dizziness, fatigue, heart rate 35, BP 70 by 54, respiratory 22 per minute with a saturation of 98%. What is the first line of action?
The atropine.
Yeah.
Atropine one
Brady
Two
with a-
oxygen and atropine.
Way oxygen. So inject atropine 0.5 milligram IV, supplement oxygen. That is, but purpose of the correct way of treating is the bradycardia should be corrected because it is hemodynamically unstable also. So atropine is not effective. What you have given is not effective after 5 minutes. What is the next drug and its dose?
Dopamine or epinephrine infusion, sir.
Very good. So dopamine 2 to 10 micrograms per kg per minute. 74 years old female, complaints of dizziness, heart rate is 180, BP 110/74, respiratory rate 80. That's 98. EKG shows this.
Supraventricular.
Supraventricular tachycardia.
Supraventricular tachycardia. Very good. This is SVT. What is the first management?
Vagal maneuver.
Is followed by
Vagal
Strategy
maneuver.
research.
IV.
Very good. Vagal maneuver. Vagal maneuver is not effective. What is the next step?
IV adenosine
Adenosine.
6 mg followed by 20 ml push. IV push.
Injection of adenosine 12 milligram IV, and if it is not responding, you can repeat. 49 years female has been taking antacids for 6 hours because of epigastric pain. Heart rate is 92, BP 118/72, respiratory rate 14, SATs 96. What to do as the first step?
12 lead
Taking
ECG.
line 12
Give
DCG.
oxygen and 12 lead ECG.
Yeah, you must take an ECG. Okay. Order 12 lead ECG. Apneic patient with good pulse is brought to ER. While examining heart rate starts to decreasing, what is the first step to do now?
Open up.
Giving.
Here the catch is here. Apneic patient
Giving.
arriving with
Secure
a
an
good pulse.
airway.
Rescue breathing.
Giving
So
rescue
do
breathing.
airway maneuver and start assisting ventilation because the bradycardia is due to hypoxia. Okay, so good pulse as he arrives is starting to decline because the patient is continuing to be apneic and becoming hypoxic. So first step is to ventilate, airway maneuver and start assisting the ventilation. What is triple airway maneuver?
Head tilt, chin lift, and jaw thrust.
Head tilt, jaw thrust and opening the mouth called triple airway maneuver. What cautions to be exercised before doing the triple airway maneuver? Already you have said.
Cervical spine injury.
Cervical spine
Rule of
injury.
cervical spine injury. What is the precaution needed during ET tube suction during resuscitation?
Giving
Adequate
you should not
pre-oxygenation and
stimulate
stimulate the vagus.
Simulate what? Arena, is it?
Vegas.
Answer, suction only during catheter withdrawal. The suction should not be on when you are introducing the catheter. It should be cut off with the thumb valve or just off, and you introduce the catheter into the ET tube, then switch it on, and while you are withdrawing it only, the suction effect should be there. And the duration should not be more than 10 seconds. These are the two precautions you have to do. 64-year female complains of right arm weakness, BP 140/90, pulse 78, respiration 14, saturation 98, EKG shows this. So, what to do in this case?
CT, non-contrast CT.
First thing is perform Cincinnati stroke scale. What is Cincinnati stroke scale? Here patient is complaining of right arm weakness. What are the components of Cincinnati stroke scale? Have you heard of this terminology?
Yes.
Okay. Patient appears positive for stroke. Vital same, glucose within normal. What is the next step?
Get the CT scan done.
So roll out
Order HCT. Excellent. Or 48 male complaining of crushing substernal pain, cold and clammy, BP 58/32, pulse 190, respiratory rate 18. SATs not recordable. EKG is shown here. What to do? So this is the EKG.
Monomorphic VT, we will do a synchronized cardioversion. Since the patient is
The
unstable.
diagnosis is it's a VTAC or a VFib?
VTAC, sir. Monomorphic VTAC.
So wide complex tachycardia, synchronized cardioversion is the answer. What is the acceptable value of EpCO2 after return of spontaneous circulation?
More than 25. Sir. Normal within 35 to 40.
35 to 40.
to
It should be
40.
almost normal. Okay? Then only it is considered as a good resistance. What is the contraindication to therapeutic hypothermia after return of spontaneous circulation?
The patient is responsive.
Conscious response.
If the patient is responding to verbal commands, there is no need for therapeutic hypothermia. What is the risk of using a tie to secure the airway instead of an adhesive plaster? For example, a bearded patient, you use a gauze tie instead of, because you cannot stick a plaster. What is the risk?
Can compress
Dislodgement.
and
Venous return from the head and neck can be obstructed. Okay. What is the dose of IV fluids to treat hypotension after return of spontaneous circulation?
10 to 15 ml per kg, sir.
10 to
15 ml.
15 ml. 1 to 2 liters roughly. Okay.
Yes, sir.
So that is the. What is the minimum systolic BP to be maintained after return of spontaneous? Already answered that is 90 millimeter. What is the priority after return of spontaneous circulation?
Securing the airway, sir.
Optimize ventilation and oxygenation. So supposing we have been doing manual ventilation or assisted ventilation with an AMBU, you must make sure that the patient is either not hyperventilated or hypoventilated. So oxygenation and ventilation should be optimized. That is the first priority. If return of spontaneous circulation occurs outside hospital, what is the priority in transporting this patient? Patient should be transported to an institution with facility for percutaneous coronary intervention too. So that in case it is happen to be an ACS, the patient can continue to be stable only by doing a PCA. So what is the dose of aspirin in ACS?
165 to 325
ml.
160 to 325. Very good. Preferably a chewable preparation. Patient brought to ER and ECG shows this. How to treat?
check for pulse and ECG electrodes. If all are okay, then start shipping.
And we have to check the
ECG
standardization
shows
of
a
the
flat line. It means patient is heart is not beating. but the EKG shows is systole. Injection of epinephrine 1 milligram IV, commence CPR, followed by vasopressors and IV fluids. This is the actual step which it is through asystole. But which is the preferred vein for IV access in emergency during CPR?
Brachial veins.
It is the
External.
dorsal of the hand
Cubital.
veins
Dorsal.
which we normally cannulate.
External jugular.
Cubital vein.
Cubital veins.
The anticubital vein. Okay?
Anticubital.
Always better to select the anticubital vein. What is the danger of excessive ventilation after return of spontaneous circulation?
Gastric. It decreases the
Earlier we
cardiac
said,
output.
Increased intrathoracic pressure reduces
Ah.
cardiac output.
Cardiac output.
So which perfusion is very important after return of cerebral circulation?
Coronary perfusion.
Coronary or
Cerebral perfusion.
Cerebral
cerebral?
perfusion.
So reduce cardiac output and reduce cerebral blood flow will happen if there is an excessive ventilation. What is the dose of shock energy for atrial fibrillation with a biphasic current? How many joules you have to use?
100 to 120 joules. Sir.
100 to 120. 20 to up to 200.
120 to 200.
How time can be taken to check pulse? During how much time can be taken to check pulse
10
during
seconds.
DLS?
Less than 10 seconds.
Less than 10 seconds. 5 to 10 seconds. What is the contraindication for nitroglycerin use in acute coronary syndrome?
Posterior part of the heart.
Inferior.
Inferior
If it is inferior wall
wall
MI,
MI and
it
the
will
use
not
of
give
phosphodiesterase 3 inhibitor for the
24 hours
past
before
24 hours.
so right ventricular
ventricular
infarction
infarction.
is a nice important contraindication. Which is the safe duration? What is the safe duration and temperature of targeted therapeutic hypothermia?
For 24 hours,
24
36
hours.
degrees Celsius.
At least 24 hours, 32 to 33, 36 degrees.
12 to 24 hours. Temperature is 32 to 34 degrees.
34 degrees.
Is cricoid pressure required during ET intubation during CPR?
No, sir.
No, sir.
Not necessary. Okay, not necessary. What is the risk of high FiO2 after return of spontaneous circulation? This is oxygen toxicity. We should continue after first shock and 2 minutes CPR. What to do?
Shock.
Give a second shock. Okay, give second shock. Already that answer displayed and what is the dose of epinephrine to treat hypotension after return of spontaneous circulation?
Should be infusion.
0.1 to 0.5 mg per kg per minute. Which sign indicates cardiac arrest in an unresponsive patient? This already we saw in the ACLS also. Gasping breath. Anginal respiration, agonal respiration, weak irregular pulse, cyanosis, slow pulse. Which one is the answer?
Agonal respiration.
Agonal respiration. Okay. After CPR for 2 minutes, no palpable pulse. EKG shows this. How to treat?
Pulseless electrical activity.
Epinephrine IV 1 ml.
That epinephrine IV.
AV dissociation here. The third degree heart block. Okay. So, the QRS is not following. Whereas pulseless is usually sinus rhythm. Okay. So, don't make a mistake of diagnosing PEA. And here it is irregular. So, this is a third degree heart block. So injection epinephrine 1 milligram IV, rate is still low and early pacing. Okay, that to treat this. In unresponsive apneic patient, carotid pulse is palpable. What to do? The choices are
Rescue bridge.
these are the 4 options, and the answer is rescue
Rescue
breathing is the
breathing.
answer. Very good. So these are the questions that we thought of preparing for the ACLS and BCA. Okay, so that should give you a rough idea to how to do Now we will go to see some of the common EKGs that are given in the exam. What are the characteristics of a normal sinus rhythm? Initially, we just see some basic points about ECG and then go on to analyze individual variations. When you say something is a normal sinus rhythm,
P
what
wave.
are the things?
P wave is followed
There
by
should be a P wave
Yes, sir.
followed by a QRS.
QRS.
So there should be a P wave followed by QRS, then there should be an upright P wave. Okay? And so rate is about 60 to 100. Rhythm should be regular. One P wave preceding each QRS, and the PR interval should be between 0.12 to 0.20 seconds, and it should be constant in duration. QRS all should be same, and QRS duration not less than 0.12 and constant in width, and QT interval not less than 0.44 seconds and constant in length. So these are all the characteristics of a normal sinus rhythm. What is sinus arrhythmia?
With the respiration, the heart rate varies. Rhythm becomes
Variations in respiration with the breathing. Okay, so that is the sinus arrhythmia. ECG, presence of sinus P waves, variation of the PP interval. That is the interval between the two P waves, which cannot be attributed to either SA node block or the premature atrial contractions. When variations in PP interval occur in phases with respiration, that is called sinus arrhythmia, and in whom it is very common.
Athletes.
In children.
elderly.
Sinus arrhythmia is very common in children more than athletes. Okay? Shown here are the P waves in lead 1 and V1. Are they normal or abnormal?
Abnormal.
is negative.
So what is this? This here is a
Bifid.
positive in lead with the rhythm is sinus. However, may display 2 humps as shown here, one in blue and one in red. This is due to the fact that atria are not depolarizing simultaneously. So right and left atria are contracting with a little bit of gap. So first right atrium contracts, then the left atrium contracts. And here the P wave in lead 1 may be biphasic due to negative deflection caused by depolarization of the left atrium is directed away. So here the left atrial contraction is depicted as a negative deflection. And here it is an enhanced hump, the enhanced negative. So what do you call this?
P mitral.
P mitral. Left atrial
Yeah,
enlargement.
this is
P
P
mitral.
mitral. Very good. And what is this?
P pulmonale.
P pulmonale. Excellent. So it is a P pulmonale. Okay. So bifid P wave or a notch P wave is P mitral. Peaked or higher than normal upstroke of P wave is P pulmonale. Okay. That's where you differentiate. What is seen in this? We
Atrial
have highlighted
fibrillation.
this here.
Skipping of beats. Skipping of cues.
Skipping of beats.
Here.
There you can see in this lot of continuous short spikes. Can it be atrial fibrillation between the QRS
Wave
complex?
is absent.
Hmm?
Atrial
Irregularly
fibrillation.
interval reciprocal key wave. So
If
this could be atrial fibrillation. Okay, normally this is the commonest ECG that will be given in OSPI. What are the other changes that happen in atrial fibrillation? Apart from the fibrillatory atrial waves, which have been highlighted in the boxes here, what other changes can happen?
Tall
QRS
QRS.
complexes are usually normal or shortened. Okay, it should be 0.12 of 120 milliseconds. But usually complexes are very narrow, very small. And fibrillatory waves may be very fine or very coarse. It is the height of that fibrillatory waves. It may be less than 0.5 or it may be coarse with more than 0.5 millimeters. And what is the mechanism of atrial fibrillation? Why does it happen? Is it originating in SA node?
Atrial contractions are more
Ah.
than what we are expecting. So it is not being able to detect in the ECG.
Okay. Focal activation originating from the pulmonary vasculature. Multiple small wavelets maintained by re-entry circuit. Okay. What is rapid ventricular response to A? There are two types of responses. One can be rapid ventricular response, other is a slow ventricular response. So if the ventricular rate is more than 100 beats per minute, then it is called rapid ventricular response. And if it is less than 60, it is called slow ventricular response, which is caused by hypothermia or digoxin toxicity. The causes of slow AF are hypothermia and digoxin toxicity. So how to calculate the ventricular response in atrial fibrillation? Because the pulse is irregularly irregular. You cannot take the two RR intervals. It will not be the same. So how will you calculate the ventricular response?
In lead to count the RR QRS and
number of R waves in,
R waves in a
6
long
seconds.
rhythm strip. Okay, we have
Into
discussed this earlier in
10.
one of the classes. So if the rhythm strip is taken for 6 seconds, then you multiply with 10. If the rhythm strip is taken for 10 seconds, you multiply it with 6. Okay, that is how you calculate the ventricular rate. The ECG is shown here. What is seen in this EKG?
my acute myocardial infarction.
We have highlighted the abnormalities for your EC reference. Lead to
Inferior and lateral.
Inferior.
Inferior.
Inferior and lateral wall MI.
Inferior and lateral wall MI. So this V2, V4, V5, V6, you say it is lateral wall MI, or is it a reciprocation of inferior wall response? Usually anterolateral is more common than infrolateral. Okay, so what you have to see is ST elevation is there in L2, L3 AVF, and reciprocal ST depression in V4, V5, and V6. So the diagnosis here is
Inferior volume.
Inferior volume.
ST elevation MI. ST elevation inferior wall. Okay. What are the likely clinical features of this condition?
Chest pain.
Chest pain, very good.
Sweating, diaphoresis,
Chest pain, hypotension, bradycardia or heart block. Okay? So contrary to anterior wall infarction, which may usually present with tachycardia, the inferior wall is always accompanied by bradycardia and hypertension. Okay? What are the important considerations in this condition, in this type of presentation? What should you do actively in this case?
If it is STEMI, we go for a thrombolyte.
Preload sensitive. This inferior wall infarction is very preload sensitive. So it is sensitive to volume. Too much of fluid will cause strain on the right ventricle, and nitrate should not be used at all. And the early reperfusion therapy should be achieved. STEMI can be associated with posterior wall involvement, which will increase the mortality. We
First
have
degree
given a
heart
clue
block.
here. Huh? What happens to the PR interval?
It is prolonged.
It is getting prolonged. Okay. So progressive prolongation of the PR interval. What is the diagnosis?
First degree heart block, sir.
Second
First
degree.
degree heart block
Second
is
degree
the
second
constant
degree.
step. Second degree, Mobitz type 1.
Mobitz type 1.
Second degree AV block. What is the other name for this block?
Winky-back phenomenon.
Winky-back
Winky-back
phenomenon.
phenomenon.
Fantastic. It is called Winky-back phenomenon. What is the mechanism of this block? All arrhythmias, you should be able to say how does it happen. Okay? So this is the reversible conduction block at the level of the AV node due to nodal cells progressive fatigue. So there is a re-entry, reversible conduction. Instead of going forward, the current passes in the backward direction. What are the causes of this block?
The patient are beta blockers or calcium channel blockers.
Beta blocker or calcium channel blocker. It can be due to drugs like beta blocker, calcium channel blocker, digoxin or amiodarone. Any other condition, any other causes other than drugs can cause because of inferior MI, myocarditis or increased vagal tone also can cause this. And cardiac surgery, especially after mitral valve replacement or Fallot's septrology, this can be happening. What is the treatment needed?
Can give atropine if needed. Pacing can be done, sir.
Atropine.
If it is symptoms or
Benign arrhythmias do not require any treatment if the patient is asymptomatic, but symptoms respond to atropine if there is a bradycardia. Okay. Right. What is seen in the circles? This is ECG.
Q.
S1, Q3.
Within the circle, are you seeing anything different? Are you seeing a straight line here?
Pacemaker.
It is a pacing spikes, pacemaker spikes. Okay. What do you see in the rectangles?
Assisted breath.
Ventricular
Wide QRS complex.
QRS.
Okay. Which chamber is paced and how is it identified?
Ventricle.
Pacemaker.
Ventricle is before QRS complex. The spikes are there, so ventricle may
Ventricle
be paced.
Ventricle is paced. So the spike is before the QRS. If it is before the P wave, it is atrial pacing.
Atria. Yes, sir.
Okay, right. Ventricular pacing spikes precede the QRS complex, and what is shown in the red arrows here?
Atrial pace.
Atrial pacing spikes, singular chamber atrial pacing spikes. Okay, right. What do positions 2, 3, and 4 mean in this? Usually, this is how a pacing is described. So, position 1, we say it is the chamber pace. Then position 2, we say it is the chamber sense, response to sensing and rate modulation. So, what is the meaning of what is being sensed?
The intrinsic sensitivity of the heart. Activity of the heart.
Intrinsic activity, yes, it is not a pacemaker stimulation. It is the heart's natural or intrinsic contractions which are sensed so that the electrical stimulation by the pacemaker can be stopped during that time. So the sensing is mainly for the sensing of the intrinsic activity of the heart. And response to sensing can be either it can inhibit or it can trigger, or it can do both the functions. And rate modulation, it can have a normal stimulatory mechanism or it may have no stimulation at all. So position 2 refers to the location where the pacemaker senses native cardiac electrical activity. Position 3, pacemaker responds to sensed native cardiac activity. And position 4, ability for rate modulation designed to meet the physiological needs like excitement or exercise and all those things. You can modulate the heart response. What does this EKG show?
Right bundle branch block.
Right bundle branch block. How do you say that?
In V1 and V2 RSR pattern.
Very good. V1 and V2, we have RSR pattern. So this is right bundle branch block. The features are typical RSR pattern in V1 and V2. Widened S wave in lateral leads. So S waves are quite wide in 4, 5, and 6. And appropriate discordance in lead V1 and V2. What is this, the meaning of this particular description? Appropriate discordance in lead V1 and V2. Is the T wave normal here? You said there is an RSR pattern, that is R wave has got two spikes here, followed by the T wave.
Inversion.
This is the discordance. Okay, so the ST segment and T wave changes that happen following the RSR pattern or the spiked R wave is called the appropriate discordance in V1 and V2. And how is the RBB pattern caused? Again, the mechanism. Right bundle branch block. So there is a blockage of current, delay or block in the electrical signal traveling down the right branch of the bundle of his, and the right ventricle to contract later than the left ventricle. This results in widened QRS complex and increased QRS duration and the characteristic RSS pattern in the ECG. Okay. What are the causes of RBB? An RBB a normal variant of a normal ECG? Do you give any importance to RBB if you find it in a patient's preoperative EKG? Usually it is considered innocuous. Okay? But if it is associated with right ventricular hypertrophy, it can be because of carpal or it can be dangers in IHD or rheumatic heart disease, or patient with ASD, myocarditis, or cardiomyopathy. In these conditions, if it is associated with RBB, then it is dangerous. Otherwise, if the patient is asymptomatic and appears to be quite healthy, RBB can be a normal variation. So this is the what is shown in this. What is the normal description? What is this wave? This one. So curved ST segment shown more than 2 millimeter and V1 to V3 followed by negative T waves. Okay. So what is this called?
This
Here if you see
saddleback sign, saddleback sign,
this is called the Brugada sign. Okay. Brugada sign and Brugada syndrome. The only thing, whenever you get an RBB, especially in a young people, please look for this change. Okay. If this sign is present, what is the significance? This can result in sudden death. Okay. So a young fellow having a RBB pattern, always look for these changes in V1 and V2, and this elevation of ST segment, instead of being low here, you can see the change in the ST segment is sloping down. Instead of that, if it goes up and if the T wave is also inverted, then that is called the Brugada sign. And Brugada syndrome is a cardiac abnormality with a higher incidence of sudden death in patients with structurally normal hearts. Okay? So that is the only danger of RBB. What is seen inside this circles?
Premature ventricular control.
Very good. What type of premature? Ventricular premature beats. Okay. What are the features of VPCs? What is their duration? How long it will be happening? It's a broader QRS complex. Okay, more than 120 milliseconds with abnormal morphology, and it occurs earlier than would have been expected for the next sinus impulse. That is why it's called premature. Okay, and it has a discordant ST segment and T wave change. Right? You can also see here after the QRS, the ST segment is going down and there is a T wave inversion along with that. Or sometimes it may be elevated with a normal T wave also. So usually followed by a full compensatory pass will be there. So if this present only, then you can call it as a PPD. So these are all the 4 features you have to remember. Wide, broader QRS, premature before the sinus, discordant ST segment, and there will be a compensatory pass. How are VPCs classified? How do they differ according to the classification? So they are classified as unifocal, arising from a single ectopic focus. So each PVC will be identical in this. For example, if it is looking like this throughout, instead of becoming like this negative deflection, here this is more positive, whereas here this is more negative deflection is there. So instead of having this combined positive and negative, if they are all uniformly positive, then it is called unifocal PVC. Then it will be multifocal if you have 2 or more ectopic from multiple QRS morphologies, like negative alternating with positive, then it is called multifocal. And they can occur in repeating patterns also. So it can occur as a bigemini or a trigemini or quadrigemini or a couplet and NSTV variant. What are the causes of PVC? And how is it treated?
Hypotension, pain, electrolyte abnormality.
There, how will you treat ASVT? I mean PVC. So anxiety, sympathomimetics, excess caffeine, hypokalemia, hypomagnesemia, myocardial ischemia, and digoxin toxicity. All of them can cause PVC, but in some people, this anxiety itself may be causing PVC. So there it is more you treat the anxiety, it will disappear. And the occasional VPCs need no treatment if it is not regularly occurring. PVCs that transform into ventricular fibrillation, previously mediated by the R and T phenomena, should receive immediate defibrillation. It can also be controlled with beta blockers, calcium channel blockers in case of anxiety and symptomatically induced VPCs. What is seen in this?
SVT.
NSVT. Rapid ventricular rate, QRS complexes. So diagnosis is supraventricular tachycardia. How to differentiate between sinus tachycardia and SVT?
P wave is hidden in SVT.
P wave is not present. Very good. So it may be hidden. A normal P wave will precede QRS in sinus tachycardia. This is not the case in SVT. What is the definition of SVT and how it is classified? So any rhythm arising above which level? Supraventricular. So where should it originate? So SVT
Above
refers
the
to any tachydysrhythmia arising above the level of bundle of Kish, and is classified based on the site of origin. It can be atrial or AV nodal, and it can be regular or irregular. So this is how SVT is classified. How is it SVT treated? Already I have shown. Just for hemodynamic instability like angina, hypotension, altered mental status, hypoxemia, and if the patient is hemodynamically unstable, then go for synchronized cardioversion. Earlier slide we talked about vagal maneuver. It is only for patients who are hemodynamically stable. Other people should have, if the hemodynamic stability is not there, always try to convert it to sinus rhythm with synchronized cardioversion. And vagal maneuver should be done in supine position. Valsalva maneuver, application of ice on face for non-pharmacological methods in stable patients. And first line medication is adenosine. Even in doses of 6 mg followed by 12 mg is not effective. A 61-year-old lady with diarrhea 2 days, she also takes Lasix daily. What do you see in this ECG? Is the heart rate normal? Is the P wave, is the sinus rhythm? That's how we analyze. Start from the looking for whether the rate, rhythm, ST segments. So QTC prolongation is there here. You can see there is a prolongation of QTC, which is seen more in hypokalemia because patient is also having diarrhea and taking Lasix. What are the other causes of QT prolongation?
Ondansetron, amiodarone, like
Amiodarone and
Congenital toxicity.
Antiarrhythmic agents which can cause QT prolongation like type 1 quinidine propanamide, or it can be hypokalemia, hypomagnesemia, and hypocalcemia,
Antipsychotic.
or it can be because of stroke, seizure, intracerebral hemorrhage, or brainstem bleeding. All these things can cause QT prolongation. Do you see here?
Torsade point is
Outside is
Polymorphic VT.
okay. Changing towards morphology, correct. And rapid and irregular heartbeat. It's a polymorphic ventricular tachycardia. Okay. What are the types of polymorphic ventricular tachycardia? Is there a classification? So it can be classified as torsade point, or it can be cardiomyopathic premature ventricular tachycardia, polymorphic ventricular tachycardia. So how do you treat?
magnesium sulfate.
Magnesium 1 to 2
Ah,
milligram IV.
Intravenous magnesium sulfate, followed by maintaining potassium levels within normal range and electrical cardioversion. These are the treatment for this particular condition. What is shown here? Does it look like bloody QTC prolongation primarily in the ST segment changes are all? What are the causes of this? Is hypocalcemia. Okay. And these are the causes of hypocalcemia. This is another ECG. What is very glaringly in this? So sinus
E-wave
rhythm,
inversion. 2, 3 AVF
P
even.
waves here in V1, V2. So peak to P wave in V2, right axis deviation, dominant R wave in V1, and deep S wave in V6. P waves inverted in 2, 3 AVF and V1, V3. Okay, so you can see the same thing again and in the case of right ventricular hypertrophy. Right? The causes of RVH are
Mitral stenosis.
mitral stenosis include right heart failure, then
Liver congestion.
so COPD and pulmonary embolism. Okay, all these things are causes of right ventricular hypertrophy. So all R waves should not be so tall in V1. It is usually very small, and you have a large. So R wave should gradually increase in size from V1 to V6 and become taller only in V6. So if it is very dominant and very big in V1 and V2, you must always think of right ventricular hypertrophy. A 60-year-old diabetic patient who had a FEMPOP bypass, 7-hour surgery, core temperature of the patient is 34 degrees. What is seen in this? So the history given has a clue for the ECG finding.
Hypothermia.
Hypothermia. So how do you find out hypothermia? Is the ECG change that will happen in hypothermia?
Osborne waves.
Osborne wave, very good. Due to J wave. Okay, so you can see this notching here in the downstroke of the R wave. I'll show you in a picture here. So this is P, this is Q, this is R. This is the upstroke of R. When downstroke comes, there is a notching. That is called the J wave, which is classical of hypothermia. Okay. Another case, 23 years old, collapsed while playing football. And he says such episodes have happened previously. And this is the ECG of this person. What is seen in this ECG? Who is here? You see this. This is WPW syndrome. And so in WPW syndrome, this red arrow, what does it point to? The slurred QRS complex. Slurred upstroke of QRS complex. Other findings are a short PR interval, wide QRS complex, and what is the treatment for WPW syndrome?
Ablation.
Ablation, yes. Medical therapy for rate control, catheter ablation, or
Diltiazem.
PC conversion. Okay, so these are the treatment. What is seen in here?
It's stable.
ST elevation in
B3 to
B3,
B5.
B4. So you have ST elevation in. So what is the diagnosis? Anterolateral MI. What is the treatment?
Thrombolysis therapy.
Early PCI will be the definitive treatment. So 55-year-old on hemodialysis, missed the last session of hemodialysis, feels dizzy. What is seen in this ECG?
Sine wave pattern.
Primary
Monomorphic ventricular tachycardia.
monomorphic ventricular tachycardia. So
Hyperkalemia resulting in
hyperkalemia. Yeah. See, the history is also very important. He is on hemodialysis, he has missed it. So severe hyperkalemia with sine wave pattern. Okay? This may give you a clue. It may look like VTAC also, monomorphic ventricular tachycardia, but it is called the sine wave pattern. So you always take the clue from the history also. And what is the treatment?
calcium gluconate.
Correction of hyperkalemia.
gluconate.
Okay? Hyperkalemia should be corrected with administering calcium,
Nebulizations,
insulin,
insulin.
glucose, beta 2 agonist, diuretics, and severe cases go for early dialysis. Okay, we have the 65 years old with no central pulse, no respiration.
Ventricular fibrillation.
This is where you your earlier case, ventricular tachycardia in cardiac arrest, because patient has no pulse, no respiration. It is VT, but the patient is also in cardiac arrest. So how is it treated?
CPR shock.
Synchronous.
This is shockable rhythm, so immediate electrical synchronized cardioversion is required. How to decide the energy required for correction of this?
Biphasic 120 to 200 joules. Monophasic 360 joules.
Wide regular means 100 joules. It can be escalated to 150 to 200. If it is wide irregular, straight away go for 200 joules. Okay. So it depends on the regularity and irregularity of the VT. What is seen in this ECG?
Normal sinus rhythm.
Sinus bradycardia.
Normal sinus rhythm. Sinus bradycardia.
Bradycardia.
So rate is only 43. How to treat this?
Symptomatic and asymptomatic. So.
Decide whether patient is symptomatic or asymptomatic. Very good. Then, if the patient is symptomatic,
Can give atropines.
Whether hemodynamic instability is present means ABC survey. Then to increase heart rate, injection atropine 1 milligram IV is not effective. Transcutaneous pacing is not available. Infusion dopamine 5 to 20 mg or infusion of epinephrine 2 to 10 mg per kg. Okay, these are all the answers. Patient is unresponsive, no respiratory effort. ECG shows this pattern.
Pulses
Electrical activity.
Electrical activity.
What is the diagnosis? It's pulseless electrical activity. Correct. How was PECA called earlier? This name pulseless electrical activity was given later on, but earlier what was it called? It was called electromechanical dissociation, EMD. Okay?
Asystole.
What is seen in the ECG? Already we have shown one like that. Asystole flat line. So what is flat line protocol?
So check the
We should check for
ECG
pulse.
leads.
We should check for ECG leads connected properly and
Lead
Very
2 is
good.
lead 2.
Excellent. Excellent. Check the leads. Check if they are properly attached. Change the lead. Try switching from lead 2 to another lead like 1 or 3. Increase the amplitude. And if nothing works and you don't get a tracing, then you call it as a flat line. How to treat asystole and PEA?
Epinephrine.
Injection epinephrine.
Epinephrine 1 mg.
Both are treated with high quality CPR. What are the types of cardiac arrest rhythm?
Shockable and non-shockable rhythm.
Shockable and unshockable. Shockable example are
VFNT,
pulseless PT, non-shockable ACLS.
What is seen in this?
Atrial flutter.
Atrial flutter. How do you say it is atrial flutter? Your diagnosis or 2%. It's a
4 is
regular rhythm with
4:1.
between
4:1.
couple. It's a 4:1. Very good. Rate is 260 and it can be a narrow complex tachycardia. Regular atrial activity at more than 300 per bar. Loss of isoelectric baseline. Sawtooth pattern, inverted flutter waves in 2-3 ABS. Ventricular rate depends on AV conduction rate. In a fixed AV block, how is the ventricular rate calculated? Already I told you. It's a fraction of the atrial rate. It is 2:1 block, it will be 150. It is 3:1, it will be 100. It is 4:1, it will be 75. How is atrial flutter treated? Again, rate control, rhythm control, and anticoagulation, just like your atrial fibrillation. These are the basic steps for treatment of atrial flutter also. What is seen in the CKG? So here you have the S1,
S1
T3 TV narrowing. Okay, indicates a massive pulmonary embolism. What are the findings? Sinus tachycardia, RBB, P pulmonary atrial fibrillation. All these things can be associated. How is PE treated?
IBC
It
filter.
can be of varying degree. It may not always
anticoagulant.
be very massive. It can be mild, moderate, and severe. But if it is severe, massive PE is a life-threatening emergency. So ABC survey, thrombolysis, anticoagulation, or surgical removal. The prevention is by IVC filters. What is shown here and how is it diagnosed?
Left bundle branch.
Left bundle
Left
branch
ventricular
block.
hypertrophy.
Left ventricular hypertrophy is correct. Your is a deep S wave and the tall R wave. Okay. So what is the criteria called to diagnose this?
Sokolov's criteria.
Sokolov criteria. Very good. Sokolov line index where S in V1 and R in V5 or V6 should be more than 35 small square. So what are the non-voltage criteria to diagnose LVH? This is voltage criteria, that is more than 35 millimeters or 35 small squares. This way, the size of the R wave and S wave. Is there any non-voltage criteria diagnose LVH?
Sagar was
Peak R wave time more than 50 milliseconds in V5 and V6. Okay. And what are the common causes of LVH?
hypertension.
Hypertension, chronic aortic stenosis. Okay. These are the two common causes. This is another case of features to diagnose irregularly irregular rhythm, no P wave, absence of isoelectric line, and variable ventricular rate. Fibrillate waves may be present as fine or coarse. Few are complexes, etc. What is low wave and what are the causes? Already we have seen that. So it is because of hypothermia and Dijak symptoms. What is shown in this?
Ventricular fibrillation.
Fibrillation, you should not take so much time for this. What is the difference between so it can be post VF. Are you able to hear me?
Yes, sir.
Okay. Waveforms are appears large and prominent, while fine VF has waveforms less than 3 millimeter, looks more like a fairly flat line. So coarse VF is an earlier stage of cardiac arrest, more responsive to defibrillation, whereas fine VF represents a more advanced stage. It is less likely to be successfully defibrillated. So what are the features of V2? How is it treated? What will the patient have when he has a ventricular fibrillation? So it is rhythm is chaotic, rate is chaotic, P waves are absent, PR interval is absent, QRS morphology is totally absent. It is a lethal or with no cardiac output. So it's an initial unsynchronized dose of 360 joules if it is a monophasic or 120 to 200 joules with biphasic. So early defibrillation is indicated, and 1 milligram of epinephrine can be given every 3 to 5 minutes until you get the. What is the indication for epinephrine in VF treatment? Why are we giving epinephrine? This is the answer. To convert the fine fibrillation into coarse fibrillation. What is shown here?
Monomorphic VT.
Monomorphic VT. Very good. Ventricular tachycardia. How is ventricular tachycardia classified? It can be classified according to the clinical presentation. Hemodynamically stable and unstable. Second classification is based on the duration, whether it is sustained or non-sustained. And morphology, whether it is monomorphic, polymorphic, Gustave point or ventricular flutter and fibrillation. What are the clinical features of ventricular tachycardia? How is it treated? The patient is conscious and they develop ventricular tachycardia. What will be their major complaint?
Dizziness.
So, will be more ventricular tachycardia is usually regular. Very rarely it is irregular, and the rate is more than 200. P waves will be absent. PR interval is also absent, but QRS will be wide, with more than 320 milliseconds. And clinically, patients with compromised cardiac output and coronary artery perfusion, VTAC may be perfusing or non-perfusing. If there is a pulse and patient is stable, then propionamide or amiodarone can be given. If unstable with a pulse, then synchronized cardioversion is necessary. And if the patient is pulseless, then defibrillate with a higher current. And if the patient has a mild pulse, then start with a lower current. So sorry, these are all the various hard blocks to describe the difference between each one. What are the changes in the serum level of hyperkalemia? What will be happening? What are the features? So you see, if the potassium level is 6 to 7, you will have a peak T wave. And if the potassium level goes beyond 7, you will have a prolongation of PR interval with a peak T wave. And if it is more than 8 to 9, you will have the QRS duration also prolonged with a further peaking of T wave, and the ST depression will happen. And once it goes beyond 9, it becomes more or less like a VTAC, producing what is called the sine wave pattern. So you should try to or develop your ability to discriminate, differentiate between the sine wave of hyperkalemia and VTAC. It is the common mistake that exams happen. So these are all the various changes that happen in that. What is this camel hump? Q2. This is happening here. It is referred to T wave that has a double hump or a double peak appearance due to fusion of T wave and a prominent U wave, which losses in hyperkalemia. So this is the U wave that will happen. So the T wave becomes shallow. So this gives the so-called camel hump appearance. Okay. We'll stop there. So all this, I have given a few ECGs, not all that is most commonly given ECGs I have given. Now I have few more OSCE-like things related to that. So what are the waveforms that are seen while you are performing a central line cannulation? What is A, B, C, D?
CVP waveforms A.
CVP, that's what I'm asking. What are the various waveforms you are seeing? At what level you see these things?
Right atrium.
Pulmonary artery catheter. That waveforms.
Right. A
Correct,
is the right
I'm
atrium.
asking, when you introduce, where will you see this space? Where will you see this? Where will you see this?
Right atrium, right
Right
ventricle,
atrium, right ventricle, pulmonary artery, and
so A is right
Ventricle.
atrium, B is right
is right
ventricle,
ventricle,
C is,
pulmonary artery,
main pulmonary stem,
and this is the
pulmonary
bridge.
pulmonary
pressure,
capillary wedge
capillary
pressure.
bed pressure.
What are the various pressures at these sites?
The A is 0 to 5.
0.
So RA is 2 to 6 millimeters, RV is 20 to 30 systolic and 0 to 5 diastolic. PA is 20 to 30 systolic, 5 to 15 diastolic. Edge pressure is 4 to 12 millimeters of mercury. What are the lengths at which these sites can be reached when the PA catheter is inserted, either by IGV route or by subclavian route? What are the
25
various
centimeter through
25, 30,
35.
distance to right atrium? 10 to 15 by subclavian and 15 to 20 from jugular and 30 to 40 from femoral. And right ventricle is reached at 10 centimeters, pulmonary another 10, and like that another part 10. So here this will stop this discussion of all this ECG and ACLS. So quickly I will go to the equipments and machines. Visible?
Yes, sir.
So these are some of the machines which are being shown here. Can you identify all of them? Have you all had a chance to see this type of machines?
Yes, sir.
Because
Yes, sir.
nowadays you are all used to this one, the right extreme.
Yes, sir.
Yes,
So what
sir.
are the first three ones?
Boils. That's
Go.
the first one is basic boils machine.
So what is the major difference between this workstation which you are all now very familiar with and the earlier machines?
The
It-
voice is
Pneumatically,
It has only pneumatic
component.
boils.
This is all of them are pneumatically operated. So even if power is not available, electricity is not required to operate these machines. Whereas you require electrical power. You may have a battery backup, but it works on both pneumatic
Electrical and
and
pneumatic.
electrical supply. Okay, so that is the main difference. And how is gas supply to machines done to the all the hospitals?
Liquid oxygen tank.
Central gas
That's
supply.
only
Central
for
pipeline
oxygen.
supply and cylinders.
It can be either through a manifold room, bulk cylinders, or it can be individual small cylinders. Okay, so this is the method of transporting the cylinder. And, what is cracking the cylinder, and why is it done?
To release the pressure.
Huh?
Opening of the valve of the cylinder.
It is
Temporarily
under compressed, so it will lead to the.
to allow a certain amount of gas to be let out. Why it is done? This is a common thing done in the earlier days, but sometimes examiners may ask you this because you are all not used to this. In our student days, we used to have the E-type cylinders fitted to the machine, and every time it gets exhausted during the anesthesia itself, we will have to change that because we will have a spare cylinder. We will open that and then remove the empty one and then attach a new full cylinder. During that time, this is a routine practice to open the cylinder before attaching to the machine and let the gas out so that any oil or dust in the outlet will
Impurities
be
are not
blown away, so that you will not have the problem of fire or occlusion. Okay? So that is so if they ask you that, you must be able to answer that. Large gas supplied are using this liquid oxygen tank. Some of you would have seen this in your hospitals. And this liquid oxygen tank is called
Vacuum insulated.
vacuum insulated evaporator. Very good.
Evaporator.
What gases can be stored in them and for what purpose?
Oxygen, nitrogen, and argon.
Apart from oxygen, you can store nitrogen and argon also, especially for industrial purpose. But for medical purpose, we usually store oxygen. What is the temperature of stored liquid oxygen?
Minus 183.
Minus 180.
Minus 183. Very good. What is the standard operating pressure of the liquid oxygen tank?
16 bar.
It is about 16 bars. Okay, right. Or it can be as high as 35 bars also. What is shown in this picture? Why are you taking so much time?
Non-interchangeable screw
Visible disc.
Color coded wall outlets
Wall
with
outlets.
self-sealing valves. Okay, that is the. What is this?
Okay, sir.
Those are the color coded.
Color coded
Non-interchangeable screw thread.
hose with the probe.
Hose.
So this is called the probe portion. These are all the hoses, high pressure hose to deliver the gases. Okay? Color coded high pressure hoses with their diameter specific probes. And what is this? Again, high pressure hoses delivered from the ceiling. Okay, so this is called the ceiling pendant or the ceiling gas outlet. This is wall outlet, which will be at a reachable height. So this will be a very high to avoid. Why this is done instead of this? What is the purpose of hanging them from the roof instead of connecting it to the wall? Just logical thinking. If you
It is
connect it
connected
to
in
the
the
wall,
floor,
how will
sir.
it go? It will lie on the floor, isn't it, before they reach the machine. Whereas here it can directly drop down. So tripping can be avoided. So the accidents in theater are avoided by the ceiling hoses. What is this?
Pin index.
Pin index.
Pin index connection to the machine. Okay, non-interchangeable screw threaded connection for different gases, which is going to the hanger yoke assembly in the machine. And this is the oxygen nitrous oxide hoses attached to the back of the machine in majority of your, these are all another thirds of wall outlets. What are the components of high pressure segment? You know, anesthesia machine system is divided into high pressure,
High pressure,
intermediate, and
intermediate
low
pressure,
pressure.
low pressure systems.
So what are the components in high pressure segment?
From the pipe.
Cylinder,
Okay.
yoke
Hanger yoke
assembly,
assembly,
This
pressure gauge,
Important pressure gauge
and
and
pressure
then
regulator.
pressure regulators.
Components of intermediate pressure segment
pipeline,
can be pipeline connection inlet,
Pipeline.
it can be oxygen
The
flush,
flush
it can be
and
flow.
flow control ones.
Components of low pressure segment,
vaporizer and flow meter.
Vaporizer and the
outlet after the,
outlet.
well, vaporizer, pressure release device, and common gas outlet. And they all come under low pressure segment. Who are the pressure systems in anesthesia machine classified and what are their values? I've already seen that. High, intermediate, and low. So this conversion you should not remember. That is conversion from kilopascal to what is M bar?
Millibar.
Millibars. M-I-L-L-A. Millibar. And 760 millimeters of mercury is another method of measuring the pressure. Centimeters of water is also another method. And pounds per square inch. So you have kilopascal, you have millibar, you have millimeters of mercury, you have centimeters of water, and you have pounds per square inch and atmosphere. So you should know the interconnection between these various methods of expressing the pressure value. So what is the effect of barometric pressure on the concentration of a delivered concentration of a volatile agent? Will it get altered or will it be the same? Supposing you give anesthesia at a high altitude like Ooty or Kodaikanal, where the ambient barometric pressure is lower than the sea level, will there be a increased output or normal output or decreased output?
High altitude it is increased.
It will get increased because the
Density.
pressure is a part of the ambient pressure, but the concentration will remain the total this thing will be the same. Partial pressure will be the same. For example, if you give 1% isoflurane at sea level, the concentration is 1% of 760 millimeters, which is 7.6. But when you give it at a value of 630, the output will become 1.2. But the concentration will be the same. The partial pressure will be the same. So the common questions examiners ask you is, do you have to recalibrate the volatile, the vaporizers at a higher altitude? The answer is no, because the partial pressure is the one which determines the efficacy of the volatile anesthetic agent. So it will not alter based on the ambient temperature. Even though delivered concentration will be higher, it will compensate for the low atmospheric pressure. So the partial pressure will be the same. So there is no need for altering or making adjustments in the vaporizer. What are the small cylinders connected to the machine? Where are the small cylinders connected to the machine? If you are connecting an E-type cylinder, where is it mounted?
In hanger yoke assembly.
It's called the hanger yoke assembly. Okay? The cylinders are connected to the machine to a part which is called the hanger yoke assembly. What are the parts of this hanger yoke assembly? These are all very basic questions. Board seal straight away. So it can be body is the principal framework and threaded into this machine. Okay, this is the body to support that. Then there is a retaining screw. This white thing is called the retaining screw. Okay, which is threaded to the distal end or the yoke. Then there is a nipple. Okay, this is the nipple where which the depression or the opening in the cylinder will fit into. And it has got index pins here. If you look at the closer way, it will be having an index pin. Then there is a board seal. So you must remember all the parts: body, retaining screw, nipple, and board seal. And a filter also there, which is not visible. Once it goes into that, this portion has a filter also. Okay. So because you are all used to your workstations nowadays, many hospitals may have these old machines and they will show you these parts and ask you to identify. So please remember all these parts so that you can not get fooled by the questions there. Okay, this is the close-up view. So this is the body. This portion is called the nipple. Around this nipple only you insert the board seal so that there is no leak of gas that will happen. And these are the two pins for the pin index system. This is the retaining screw, and this is called the toggle lever. You can remove. You can see here it has been opened here. So this is also called the toggle lever, where it can be rotated clockwise or unclockwise to insert the cylinder and then retain it in its position. So what is shown in this picture? This is from your newer machine.
APL was
You have the APL valve, you have the pressure gauge for the airway pressure, and you have the lever to switch over from manual to ventilator. What is this picture showing?
Borden's pressure.
Borden gauge.
This is the pressure gauge and the oxygen pressure gauge with the Borden principle, how it is working. So this picture is showing that. And what is this component? This you see only in the older machines. In your modern workstations, these are all not exposed. Whereas in the older machine, if you lift the tabletop, you will see all these things under your vision. So this is the pressure regulator. Okay, and the downstream. This is the outlet, downstream outlet, and pressure regulator with the pressure gauge is also there. And this is the two-stage regulator. You have two pressure gauges. So these are usually attached to the bulk cylinders which are used in the ward in the earlier days. So some hospitals may have this still and they may ask you that. Identify what is shown here. This is the. Have you all seen a E-type cylinder separately?
Yes, sir.
will be attached to your back of your machine. Okay, it's a valve assembly of a cylinder, both front view and the back view. This is called valve assembly. These are all the components. Can you name them? So this screw is fitted to the neck of the cylinder, and you can see these are all the anti-leak devices. Just like a plumber uses a fine white tape, they have screwed it into the neck of the cylinder with a tape so that there is no leak. And these are all the various parts of that. Okay, so this is the cylinder valve which you try to open. Then there is the gland nut, and there is the sealing. Bodak seal is there. Then this is the opening for the gas to come out. So this is the cylinder part, and these are all the holes for the pin index. So the pin will be there in the hanger yoke assembly, and these holes have to fit in to prevent wrong mounting of a cylinder. Okay. So this is a very common picture that can be given and asked you to identify. So please remember all these points. This is the
Bodak seal.
Bodak seal. Okay. So what is the thickness of that Bodak seal? About 2.4 millimeter. And what is this black portion? It's called the neoprene rubber. Okay. So this is an aluminum ring into which this neoprene circular rubber with a hole in the center is attached to that aluminum ring. Okay. So the whole thing is the Bodak seal. What are all these things?
The cylinder open. The different size of cylinder openers.
These are all called the key for various types of key to open the compressed gas cylinders. What is shown here?
Pressure regulator.
Pressure regulators.
Pressure regulator. So these are the adjustment screw, the spring, the diaphragm, and the regulator pressure outlet, and the high pressure inlet. So these are the parts.
Different pin index system.
Pin index.
For different cylinders.
For various gases. Can you identify what are all the pin indexes of these gases?
First is oxygen.
Oxygen.
Hmm.
And
Second is
second is
nitrous oxide.
Hmm.
Third one is
one.
air.
Next one is carbon dioxide.
Last one is ethanol.
What is the last one?
Ethanox.
Ethanol. Okay, so oxygen, nitrous oxide, air, carbon dioxide, and ethanol. Okay. So the position is 2,5 for oxygen, 3,5 for nitrous oxide, and 1,5 for air. And carbon dioxide is 1,6 and ethanol is 7. What are the various sizes of cylinders, their capacities, pressures, and tare weight?
That is A to E.
A to
And
We have B, E, F, capacity, pressure, tare weight is also there. So E type is the commonly used type in our machines, and the tare weight, that is the empty weight of the cylinder, is 5.4 kg. It can withstand the pressure of almost 2000 psi, and the capacity will be 660 liters. Which type of cylinder is usually fitted in the anesthesia machine? It is the E-type cylinder. So what is shown here?
Cylinder pressure and pipeline pressures of oxygen, air,
Pressure gauge. So pressure gauge for nitrous oxide, air, and oxygen on the left side for pipeline, top row, and cylinder for the bottom row. Okay. So it is all given here both symbolically as well as written. Pressure displayed numerically on the right side. What information is available from the cylinder label? Usually the cylinders, when they come from the factory after filling, they will have a label around their neck like this. Okay? So they may have all this information like the content, chemical symbol, physical state, volume, whether they contain any flammable or non-flammable gas, service pressure, cylinder size code, product license, etc., etc. And this is called the bull nose or hand wheel valve type outlets. This is a cylinder with a pressure gauge fitted to the head itself. Cylinder with integrated pressure gauge. What is the service pressure of a cylinder? This is a common question they may ask you.
70 degree of Fahrenheit.
Definition is defined as the maximum pressure to which the cylinder may be filled at 70 degrees Fahrenheit. Okay? It is the maximum pressure up to which the cylinder can be filled. How much more pressure they should withstand after this fill it at the service pressure? They should be withstand at least 1.66 times of the service pressure. Why this is not filled to the maximum pressure? Why they are always filled with a lesser pressure compared to the maximum pressure they can withstand? What will happen if the cylinder is transported from a cold region to a very hot region?
Expansion.
It will expand and explode. Okay, so they will all never be filled to the full capacity and also pressure to avoid explosion. Okay, so to withstand the varying temperatures, especially hotter climates, the gas will have a tendency to expand, and once it expands, it will have higher pressure, and then there is a chance of cylinder exploding. So they always fill it up to a lower level capacity volume wise as well as pressure wise. Okay. What are shown here?
Flow meters of different single tube.
It's a single flow tube for flow meter of different gases. Okay, we have only a one flow meter tube for each gas. Different gases are there. You can see the hand is blocking, otherwise the color coding will help you to identify. And what is this flow meter?
It is a double tube.
It's a twin flow tube.
Nitrous oxide gas.
Control knobs. Okay, so three gases are there: oxygen, nitrous oxide, and air. This is commonly what you are seeing in your nowadays the present station, and they have twin flow tubes. What is the purpose of these twin flow tubes?
For low flow, and we are keeping surface.
It is mainly for low flow anesthesia. What is this one showing?
Electronic
Single flow tube with a digital display of control knobs, pipeline pressures, and all gases. And this one?
Electronical.
This is the electronic flow meter touch screen model. Let us. What is shown here? Forget this portion, because this also is a twin flow tube what we have seen. Apart from that, what is this?
It is auxiliary.
This is called twin flow meter for three gases plus protective bar is there in front of this to prevent the accidental movement of the knob, and there is an auxiliary flow meter for air and oxygen. Okay. What are the parts of this flow meter tube that you normally see? All these things have been marked and masked here. So what is this portion? We are viewing it from the side. This is the control knob, fluted control knob. Okay, so this is the flow control knob which is fluted. There is a valve stop. There is a needle valve. So this is called the needle valve flow meter also. This is the valve sheet. This is the float or the bobbin. This is the float stopper. This is the float. Then there is a tapering of the tube. Then there is a float stop at the top also. Gas circulate to the manifold. And what are the safety features on or downstream of the back bar? So oxygen failure warning devices are there. Spring-loaded non-return valve will be there. And pressure relief valve, emergency oxygen flush. All these things are the safety features that are present on the back side. What is the most important goal before using anesthesia machine?
Machine check.
No, sir, ambu bag.
Key points are you should see whether you have a ambu bag available and make sure that it is all in the working condition. And trace the path of the gases and vapors from the origin to the patient. Where is it delivered to the theater? How is it delivered to the machine? And once it is delivered to the machine, what are the changes that happen? So if you trace that, sources may be wall outlet or the cylinders hung from the yoke, hanger yoke assembly. And the high pressure is reduced by pressure regulator before gas reaches the flow meter. And oxygen failure devices are incorporated before it goes to the flow meter. And flow meter is the beginning of low pressure segment. Vaporizers fitted next to the flow meters are in the downstream. Finally, gases and vapors are delivered through common gas outlet at atmospheric pressure. Even though we start at a high pressure of 2000 pounds or psi or 60 psi, ultimately it will be delivered at atmospheric pressure of 14 or 15 psi. Okay? So these are all. Can you identify this person?
Boys, Edwards or Boyle.
Henry Edmund Gaskin
Gaskin
Boyle.
Boyle.
Okay? He is the inventor of the Boyle's machine. These are all the old models of Boyle's. This is the true picture of what we saw earlier. This is the valve blocks. Earlier we saw the black and white photograph. These are all the color photographs. So this contains body, valve, port, stem, etc. And what is the material out of which the cylinders are made? Why such materials are used?
Steel. Normally it is a molybdenum. Steel.
It is made of a material called molybdenum steel. Okay? It's a molybdenum plus steel plus chromium, alloy of molybdenum, and it is used to increase the strength and minimize weight and wall thickness. So it should not be too heavy. At the same time, it should withstand the high pressure at which the gases are filled. Okay? But which cylinders are made by aluminium?
MRI compatible.
MRI compatible. Okay. So this is the same picture I showed you earlier. Spin index safety system. What is the purpose of the spin index safety system?
Is it gas specific?
Prevent the
To
faulty
prevent
connection.
the wrong mounting of a gas. Okay? So it will oxygen hanger yoke assembly will not accept a nitrous oxide cylinder or a air cylinder. Okay, so this is to prevent the wrong mounting of the cylinders or gases. That is the answer that you have to give. And sometimes they ask about the dimensions of the pins. So they are 4 millimeter in diameter and 6 millimeter in length. All these pins are there. And the antennas has got only one pin, which is 7 millimeter long. And pin is incorporated to as a safety precaution. It was introduced in 1952. Okay? Before that, they were not there, so you can mount any cylinder in any hole. In the color coding, what is the why is the color coding? What is the purpose of doing this color coding for different gas cylinders?
To prevent
To
wrong
avoid
filling of the
misconnections.
First of all, to identify easy identification. By seeing the color, you can say, oh, this is nitrous oxide because it is blue. Oh, this is carbon dioxide because it's gray. And the second thing, even people who are illiterate, they can easily identify. You say, during the black cylinder or white cylinder, you can easily identify. And the second reason is you will not be able to, you will not be fixing it to the wrong yoke assembly to get the color faster. And the check valve assembly is another safety device in the yoke. This is the inlet. Let's skip that. What is shown in this cylinder, in this picture?
Internal cylinder.
It's not internal.
Nitrous.
E-type nitrous
Nitrous.
oxide cylinder. See, this black white is something printed on that. Internal cylinder will have half white and half blue, or full white in the neck and shoulder region. This is called the neck portion. This is called the shoulder portion of the cylinder. Okay. So name 4 people involved in the production, identification, and use of nitrous oxide into clinical practice. History. Hospitals sometimes may have history questions also.
Laughing gas by
Who are the persons who invented and then identified their characteristic and started using it? Who is the person, who is the chemist who identified nitrous oxide?
Joseph Priestley, sir.
Joseph Priestley. Okay. Then Humphrey Davy. Then Horace Wells and Quincy are the anesthetic people. Okay. The Priestley is a chemist who identified, or first who found out the nitrous oxide. Humphrey Davy was the person who then popularized it. Horace Wells and Quincy were the person who used it in anesthesia. This fellow, they are all dentists who wanted to use this for pulling out the dental extractions. What is the mechanism of analgesia produced by nitrous oxide?
NMD antagonist.
NMDA
NMDA
receptor.
antagonist. Okay. Only one mechanism.
Opioid receptor.
Action on opioid receptor.
Opioid receptor.
With an NMDA antagonism, modulation of endorphins and enkephalins, and it can activate supraspinal inhibitory pathways also. There are 4 mechanisms. What is pointing effect? It is a
The
bubbling
mixture
of
of
oxygen.
nitrous.
Nitrous will show pressure constant until the liquid, all liquids are vaporized.
Nitrous oxide is usually a liquid at room temperature. Okay. So in order to vaporize that, if you bubble oxygen, which is the gas, through this liquid, then nitrous oxide will also become a gas, and it will contain a mixture of both oxygen and nitrous oxide. So that is called the pointing effect. Compare the properties of oxygen, nitrous oxide, and air. So the cylinders in which they come, they are all having more or less the nitrous oxygen is a gas at room temperature, and the cylinder weighs about 5.9. All the cylinders, E-type cylinders, will have the same weight, and when it is fixed, the weight will differ. Nitrous oxide will be more heavier compared to oxygen, and cylinder pressure is very high in oxygen. It is about 750 for nitrous oxide, and the air cylinder is 1800. So please remember this value, because nowadays we are regularly using air in our anesthesia, avoiding nitrous oxide. So they may ask you the pressure inside a full air cylinder. It is slightly lesser than oxygen, but 1800. What is seen in this?
Internox.
Cylinder. Okay. What is the unique nature about this valve that is being used in that?
It is open only in the inspiration.
It is called the demand valve. It will open only when there is an inspiration. Of course, what is pointing effect? We have seen that. What is lamination in Internox cylinder? Internox is cooled below the pseudocritical temperature. What is pseudocritical temperature? This is another question that will commonly come when there is a discussion on Internox.
Liquefied, that maximum temperature at which it liquefies.
See, when oxygen and nitrous oxide are separately used, they have different critical temperature. is beyond which it cannot be compressed. But when both are mixed, just like your emla cream or your other mixtures that you have, they attain a new temperature under which it can be, beyond which it cannot be compressed. And that is called the pseudocritical temperature. And nitrous oxide will become liquid and settle at the bottom, and the oxygen will remain at the top. Right? So it becomes into two layers or lamina. So gas will be in the top layer, which will be purely oxygen. The liquid will be the bottom. Normally, in internal cylinder, both should be in the gaseous form. Both oxygen and nitrous should be in the gaseous form at a concentration of 50-50. Whereas once the lamination occurs, the cylinder becomes cool, the nitrous oxide will become a liquid again, and it will settle down at the bottom. So if you don't take precaution and use that cylinder, patient will receive only pure oxygen in the beginning, and later on the nitrous oxide will start becoming a gas, and you will get a hypoxic mixture with more of nitrous oxide. Okay, so that is called the lamination. And to prevent that, you can invert the cylinder several times or warm the cylinder, because it happens in a cool temperature. You can warm the cylinder before use, so that again nitrous oxide will come into the gaseous form. What are the uses of Ventanox?
Labor analgesia, to give labor analgesia.
Labor analgesia, burns dressing, or in field anesthesia, because it can be carried anywhere, portable. What is filling ratio and why it is important?
It's the weight of the
Cylinder with a
Cylinder
gas
with
to
the
the
gas.
weight of the empty.
It is a ratio. Ratio means you have to comparing two things. What will you compare?
weight
Anything
of the
in
gas in the cylinder
Hmm.
to the weight of the water of the cylinder.
Water in the cylinder.
So the cylinder filled with gas, cylinder filled with water.
Water.
That is the ratio. So the value of carbon dioxide is, what is the value for carbon dioxide? Filling density percentage ratio, weight of the gas in the cylinder to the weight of the water in the cylinder at 60 degrees Fahrenheit. For nitrous oxide, it is 68%. Why they have given carbon dioxide? It is also a liquid one, because you are not using, you don't know. Carbon dioxide is also liquid. Okay. What are the tests done to find out the stability or the safety of the cylinders? They are done as tensile strength, flattening, bend test, etc. And they have to be carried out 1 out of every 100 cylinders and every 3 to 6 months. And this is the hanger out assembly with a dummy plug. Whenever it is not fitted with a regular cylinder, you have to block it so that no dust or oil will go and accumulate at the entry point. Then how can a wrong cylinder be placed in the yoke? What mistakes can allow
Broken pin.
a wrong
The
cylinder?
broken seal.
Broken
Then
pin may be broken,
pin may be broken,
or you
and
can put two
wrong
washers.
filling of.
Two washers are placed in the port, or pins in the yoke are broken, or holes in the cylinder are too deep. All these things are happening. You can fix a wrong cylinder also. What is the name of this? This is not required. This is Wright's respirometer. Of course, that comes under the equipment. Have you all seen this equipment? Wright's respirometer and peak flow meter. Where are they used? To measure the tidal volume
In spirometry.
You can do bedside pulmonary function test using this. What is critical temperature and critical pressure? These are all old time questions which you will not be seeing, because you are not seeing the use of a U-type cylinder every day in the OT. So critical temperature of a substance is the temperature at which and above vapor of the substance cannot be liquefied, no matter how much pressure you apply, And the critical pressure of a substance is the pressure required to liquefy a gas at its critical temperature. So this definition we have to remember. What is medical air? What is the definition of a medical air? It is defined as no detectable liquid hydrocarbons and less than 25 parts per million of gaseous hydrocarbons, and particulate matter of 1 micron or less should not in the normal atmospheric air, no dew point, and low levels of nitric oxide found in ambient air. If all these things have been removed, then only it is called medical air. So for that purpose, it has to be filtered carefully. How will you calculate the percentage of oxygen when using air? What is the formula? Nowadays, all of you are using air oxygen mixture. I think you are all arbitrarily keeping 2 liters of each, or 2 liters, 1 liter, 1 liter low flow. But how much of oxygen you will be supplying if you are giving a mixture of oxygen and air? How to calculate that? So the formula is this: oxygen concentration. You have to use this formula. And the example is, if you are using 2 liters of oxygen and 2 liters of air, then you multiply. A pure oxygen is 100% oxygen. Okay, so you get 100 into the 2, whereas your air contains only 21% or 0.21 percentage of oxygen, and that is also you are using 2 liters, and the total volume you are using is 4 liters. So multiply all these things, then you will get almost roughly 60.5% of oxygen will be delivered when you are using 2 plus 2 oxygen and nitrogen. What is adiabatic and Joule-Thomson effect? One examiner from Mysore is very fond of asking this question to every candidate.
Related to rise in temperature and
What will it cause? Rise in temperature will cause expansion of gas or compression?
Expansion.
expansion of gas.
Expansion of gas. Okay. So adiabatic changes in Joule-Thomson. When a gas is subjected to sudden compression, the heat energy is produced rapidly. The reverse occurs when there is a sudden expansion. So there is no exchange of energy within the surrounding. This is what is called adiabatic change. In Joule-Thomson effect, when a gas is allowed to escape through a narrow opening, there is a sudden temperature drop. So what will happen in Joule-Thomson effect? How is it seen? In which cylinder you will see this Joule-Thomson effect?
Nitrous.
You will see it with nitrous oxide.
Nitrous.
Okay? And you will see droplets of ice formation. Okay? Because the atmospheric air contains water vapor, and there is a sudden cooling by releasing this nitrous oxide. That water vapor will get condensed and it will form small ice particles around the neck and shoulder portion of the nitrous oxide cylinder, and that is called the Joule-Thomson effect. What is shown here?
Pressure gauge.
Oxygen pressure gauge. Okay, this is another common question in the exam, especially in the afternoon machines. You will be asked about it. So, what are all the safety features you find in the oxygen pressure gauge?
Color code.
This is the Borden gauge working principle. Okay? What are the safety features in the pressure gauge? That is another common question.
Color coded.
It is color coded. Then name and symbol of the gas written over the dial. And if Borden tube ruptures, gas is vented from the back side, not on the front side. To record the anesthetist. Gauges are angled and placed in such a way that it can be easily read with the anesthetist. Instructions like use no oil, open valve slowly, or written on the gauge. And What is this? This is called the party horn. Okay, flow noise maker or party horn, and this is the principle of this Bowden gauge. When you blow air, it expands. Like that, when gas flow, that this tube tries to straighten out to show that. This is using Bowden. Let's get through that. Why pressure regulators are required in the anesthesia machine?
From high pressure to low pressure.
To prevent barotrauma, okay?
Barotrauma.
To maintain a small pressure so that you can avoid barotrauma. And also damage to the machines will be prevented. Physical principle involved is that high pressure in a small area converted to small pressure, low pressure in a larger area. So that is the simple method. Why cylinders should be kept closed. Okay, all these things. Oxygen flush valve. Sometimes we may ask you how much of oxygen will be delivered if you use the oxygen flush valve.
35 to 75.
35 to 75
35 to
liters.
75 millimeters. Okay, and it receives from the directly primary. It bypasses the pressure regulator. Okay, so when you use oxygen flush, it should be very careful that you may produce a barotrauma, and it will dilute the inhaled anesthetic. Accidental activation can cause leakage of oxygen, and sometimes the flush may be stuck. What is the difference in these two?
It is closed
Which
to
is
the
more easily likely to be activated? One on the left or in the green one?
Left one can easily be
Left one is
started.
almost on the surface. And here you can see a protective guard, just like what I showed you, the flow meter. This will protect. This is in a little depressed state, so this will not be activated. Whereas this one can just knock with your elbow, can activate that. Okay. This is the where is the oxygen flush in this? It's a old type machine, Boyle F machine. This is called. Where is the oxygen flush?
that black color.
So this is the oxygen flush, just close to the common gas outlet. Okay, so this is old type machine. If they keep it there, they may ask you. So this is the location of the oxygen flush in the older type of machine. So this is a close-up view. You can see on off. You have to turn it down or pull it up. In the up position, it is off. When you rotate it down, it will be on. How to calculate the amount of gas in the nitrous oxide cylinder? This is a calculation based on Avogadro's hypothesis. And how to calculate the E-type cylinder? Common question asked is, how will you know that how long a cylinder will last by seeing the pressure, and which law is applicable? Is the Boyle's law which is available, which is applicable for counting that. So if you have a half cylinder, how long will it last? Supposing you open the oxygen cylinder in a small nursing home, you are used to workstations nowadays, but you go to a periphery and you have only a old Boyle's machine, and you open the cylinder stem and it shows 1000 psi pressure. How much of oxygen will be left in that?
10 minutes.
The capacity is 660 liters. Okay, so it will be 330 liters. If the pressure is half, the volume also will reduce by half. Okay? So 330 liters will be there, and that will last for 5.5 hours. Okay? But based on the duration, you can also calculate like this. The hours of supply is equal to pressure in the cylinder divided by 2 divided by the liter of flow per minute. For example, if the cylinder pressure is 1000, then flow rate is 2 liters per minute, then the amount of duration you will have is only for 2.5 hours. So these are all the flow meter. So when there is a single flow, there is a dual tapering. And see here at the bottom, it is narrow. As it goes up, it widens. So that the higher flows will have a. So what is the physical principle involved in the dual taper design? What factors govern the flow of gases through this dual taper design of flow meters?
If it is low,
But,
if it is low flow, it is viscosity. If it is high flow, it is a density.
Okay, right.
Oh.
And this is the twin tube flow meter. So in the separate flow meter, low flow is the same as the tapered. Single tube does a double tapering. So how does the bobbin rotate? The bobbin, which indicates the flow,
On top of
how is it rotating? Because of the slots at the top of that. Okay? So you can see these are the slots in that. These are the various types of bobbins or floats that were used in there from the earlier days. Okay? So they were called the ball type, the non-rotating type, the skirted and non-skirted type. Okay? It's an aggregation. So we have seen the auxiliary flow meter. What are the? This is present in the modern machine, so you must know what are the features of that. I told you the identify the thing. What is this yellow arrow pointing to? And the green arrow pointing here.
Yellow arrow, we can
Flow for
attach the nasal cannula or tube for the nasal cannula. And green
arrow.
The adjustment. Knob for adjustment.
Knob for adjusting what? Okay, you try to find out and tell me before we class or tomorrow. So what is shown in this particular picture? For those who are not able to clearly see, a flow meter which you see in the wall outlet for delivering oxygen is connected to the common gas outlet through a adapter and a tubing. What is the purpose of this? And you can see the oxygen knob is kept closed. The floats are not flowing up. But the bobbin or the float in the flow meter tube is going up. Then what does it indicate?
Oxygen supply failure.
There's a leak. Okay, this is to do internal leak test. This is called the internal leak test. Flow meter connected to the common gas outlet quantify the internal leak that can happen when all the flow meter tubes are kept in closed position. Okay. So, what is transitional hybrid flow meter? The newer machines. You can see the flow control knobs are here. But what is the display here? You don't see the glass tube like this. Okay? But you can see this on the electronic thing. So it is a flow mechanically controlled with electronic display. That is called the transitional hybrid flow meter. And there is a needle valve so that flows can be generated without electric power, and flows are captured and displayed electronically. Electronic flow meters allow automated anesthesia record keepers to chart fresh gas flow. That is the reason why this is being introduced in the world. Hypoxic prevention devices in anesthesia machine. So, and minimum mandatory oxygen flow, minimum oxygen ratio, and mechanical linkage. This is called Link 25 system. How does it work? Can you see a chain going around?
14
14
sprockets
for
in
nitrous
nitrous and
oxide
28 in oxygen.
29 for
29.
oxygen. So this is how we always get a 2:1 ratio. That is how it is controlled. What is shown in this? Inspiratory and expiratory valves.
Valve.
Unidirectional valves, which are commonly seen in your bed. What is this picture? This is in the old machine. So this is a pop-off valve, or also known as pressure release valve. And this is the oxygen flush. These are the circuit changes which are seen in the newer machines. Features of common gas outlet, where the gases ultimately get delivered here. This is the common gas outlet. And it has usually a 15mm phase 15 female splitting joint with coaxial connector, and it is machine standards that it be difficult to accidentally disconnect the delivery hose from that. And the pressure delivered at the common gas outlet is 5 to 8 psi, or at atmospheric pressure. This is the back bar. These are all the goal is to mount all the vaporizers, and then you can have the newer machines have what is called the interlocking system, so that earlier machines you can use both the gases and then vaporizers at the same time, but now modern machines have the interlocking system, which are it won't allow the operation of two vaporizers at the same time. And purpose of interlocking is by preventing the two agents cannot be opened. So that is new. This many of you may be aware of, that Dragger Primus workstation display. So many things are being displayed here with all the gases and the ventilator ratios, everything. So the type of screens, what are the types of screens? You can have a touch screen. Okay? And what is a flexible screen? You ever heard of that?
Can
That
be
you can
used
shrink
in both
and
ways.
keep the display expanded fully, or you can reduce it to particular parameter that you want to do by reducing the size. Then it is called the flexible screen. And the drop down menu is usually you touch a parameter and then you have get the options, and then just like working with your computer, you go and click on that particular subdivision, then you get the work done. Fresh gas decoupling. This is present in the newer workstations. So what is the purpose of that? Is to prevent earlier both the ventilator driving gas as well as the fresh gas used to go to the patient. There's a chance of barotrauma. Whereas nowadays it is being removed or separated to prevent valve trauma and barotrauma, and that is available in what is called the piston type of cylinders. So this is the picture to show how a fresh gas decoupling is done when the valve is open, and you can see the what happens during inspiration and expiration. Then there are few things about the what is shown in this picture.
First picture is
The dial of
desflurane.
which, but
Dial of
the
ventilator.
desflurane.
And
What is
first
the
picture
thing
is
that you?
on the setting dial is 5, sir. Second one is about to transport.
Transfer.
It is in transport form.
Transport.
This is a
3 is
off.
closed.
Off.
Okay, so this is the dial off, and so all the features of desflurane can be sometimes asked, how they are filled, what is the mechanism of filling. All this is the common questions we may get with regard to the vaporizers. So there are funnel type, pre-fill, quick fill, easy fill, etc. And the maximum percentage that can be delivered with the text is the desflurane is 18%. So vaporizers classification, how they are classified based on vaporization method, regulation of output, temperature compensation, agent specific or multiple agent, plenum or draw over location. This is the classification. And the examples, we have all these things. And what is the difference between a gas and a vapor?
The critical temperature above it is gas and
Below
critical
the limit, the vapor. Okay, so the substance that has no shape or volume that occupies the space above its critical temperature. And what is the saturated vapor pressure? And what is the importance of that?
when the liquid and its vapor pressure is equilibrium, it will called that vapor pressure is called saturated vapor pressure.
Very good. So this is very important for defining the, what is boiling point of a liquid? These are all some of the common definitions they may ask you. It is the saturated vapor pressure at equal to atmospheric pressure. It is called the temperature at which the saturated vapor pressure of the liquid equals the ambient temperature is called the boiling point. Okay. How to calculate the vapor concentration using saturated vapor pressure and atmospheric pressure? The formula is saturated vapor pressure divided by ambient pressure. That is the formula that you should use. For example, for sevoflurane, the saturated vapor pressure is 20.1 bars and the atmospheric pressure is 100 bars. So, at 1 atmosphere, if we expose the if we directly pour sevoflurane onto a patient's face, you will get 20.1% of sevoflurane going to the patient. Okay, and is it tolerable? Can any patient tolerate 20% inhaled concentration of sevoflurane?
No, sir.
It will
Leads
be
to
very
toxicity.
depressant to the cardiovascular system. And that is why we have the
Splitting ratio.
vaporizers to deliver the correct proportion or the concentration of that is the purpose of vaporizer. What is splitting ratio?
It is a ratio between the gas flows bypass and vaporizing chamber.
Very good. What is the latent heat of vaporization? It is the heat required to vaporize a liquid into its gaseous form. Okay, and that is converted the mass of liquid into gaseous phase. And mechanisms of safe filling this Fraser-Sweatman tin. This is called the Fraser-Sweatman tin, which we use for isoflurane bottles. So just quickly go through all that. This is tech vaporizer. What are the features? They may sometimes show you the picture of a vaporizer and ask you all these questions. What is seen there? What is the difference between other models? What is the temperature to which the tech vaporizer is heated? That is for desflurane. And what is the reason for no output signal? What is the maximum dial setting? All these things are. And the methods and properties of common inhalation agents. All these parameters you should know for each agent, like boiling point, vapor pressure, blood gas partition coefficient, oil gas partition coefficient, and metabolization in the body. All these things you should know. And what are the properties of an ideal inhalation anesthetic agent? These are all the ones. So, checklist before use of a machine. What are all the things you should check? Can you enumerate that? First and foremost, check for availability of suction, ambu bag, and defibrillator in a theater. Okay. Then identify the source of gas supply. Whether it is coming from a central pipeline or cylinder attached to the machine. Perform tug test at the wall outlet. And in case of central pipeline supply, see whether you have a spare oxygen cylinder attached to the machine or not. And check flow for oxygen from auxiliary flow meter. Turn the on to the main power supply in case of its workstation. Check flow of oxygen, nitrous oxide and air. Check for hypoxic guard by opening oxygen, nitrous oxide. So close oxygen, nitrous flow should stop. That is how you check for hypoxic guard. Inspect the vaporizers for agent level, filling port, dial position, open and close the dial setting. And then how do you test the integrity of breathing system check? That is, close the pop-off valve, occlude breathing tube by placing a thumb over the ET3 vent connection. Pressurize the circuit to 30 centimeters of water by using 3 liters oxygen flow. Then switch off the oxygen flow. Watch the pressure gas tube for any pressure loss. Then turn the vaporizer on, and still the oxygen should be closed, and watch for any drop in the pressure. At any point, if pressure is lost, that means there is a leak inside. Then confirm that the leak does not exceed 300 milliliters per minute. Okay? And check scavenging systems, check ventilation function. If all these things are the checklist that we should do. What is shown in this picture?
Anaconda.
Anaconda.
Negative pressure. Negative pressure.
Impact of the
Pressure and
It's called the universal leak test or
Negative pressure leak test.
So how is it done?
it will connect.
This is the common gas outlet.
Yes,
You
sir.
have a
The
tube
bulb.
connected with a
Bulb.
BP bulb. Okay? So switch the machine to off position. Keep the flow meter and vaporizers also in off position. Attach a suction bulb with a rubber tube and adapter to the common gas outlet. Squeeze the suction bulb a few times to collapse it. And the bulb should remain collapsed at least for 10 seconds. If there is any gas leaking from inside the machine, it will come and fill up this suction bulb. But if the bulb is remaining collapsed, that means there is a negative pressure, no leak is happening. So that is how you will test it. And breathing system classification, we will not go into the detail. So these are all common pictures that you should be able to identify. What is this picture showing? Can you identify these two pictures? One is called the parallel lac circuit. The other is called the parallel vein circuit. Okay? So this is a lac circuit with the vein circuit. Vein circuit nowadays comes with a coaxial single tube. Earlier version you have a parallel circuit also. So these are all the various types of Mapleson classification. I'll just skip through that. Vein circuit, you should know all the details about vein circuit because that is very frequently used. You should be able to identify all the features and under what Mapleson classification vein comes?
Semi-closed.
Mapleson D. Okay.
D.
What is apparatus dead space? How is it measured? There is dead space not taking part in gaseous exchange caused by the machine or the connections. Okay? It's measured at the level of the expiratory valve in the afferent reservoir system or at the point of entry of fresh gas flow. So this is called the afferent reservoir system, and this is the expiratory valve. This is the efferent reservoir system, the fresh gas flow entry. And in the circle system, it is at the junction of both the inspiratory and expiratory limb. What factors alter the apparatus bed space? You can increase or reduce. So tracheostomy helps in reducing the apparatus bed space. And what is the apparatus bed space calculated in vein circuit? It is almost negligible because the fresh gas is delivered close to the patient. So this is the afferent limb in the patient. So gases, fresh gas tube is inside the outside tube. And what is this tube?
T tube.
Have you seen this? Tube with a side arm like this, and this is the single limb O tube breathing circuit. The length is available in various lengths: 1.5 meter, 1.8, and 2.5. And this is how it will be connected to the tube system. Okay? And then it is the way the limb O circuit is attached to the circle. Uses are the single limb circuit, useful in anesthesia circuit as well as the Mapleson rebreathing circuit, and also it can be used in ICU ventilators. And so it is called the universal breathing circuit. It's very useful mainly in head and neck surgery, where you want to keep the machine away from the surgical field. This will have a long length. It is almost like a brain circuit because the inner tube has the first gas delivery. So minimal apparatus dead space, and it can be away from the field.
Water flow.
Waters to and fro.
Waters to and fro canister. Very good. Under which Mapleson classification this equipment is considered?
Mapleson A.
C. This Mapleson C system. What is this?
Self-inflating bag.
Ambu bag. So this is another common question that you have to be prepared for. What are all the parts of that? Then this equipment.
Soda lime.
Soda lime.
See what absorbent. In the single canister.
Double canister. And so these are this is more in the modern workstations. You have this sort of single canister in under the usually not very visible. Whereas in the older machines, it is very visible and present in the outside. And the reaction of soda lime can be asked. So all of you must know that carbon dioxide combines with water, bicarbonate formation, etc. What is Monday morning syndrome? What happens and how can it be prevented? This is pertaining to our newer machines.
Yes, sir.
Not heard of this?
We heard, sir.
This is refers to a potential risk of carbon monoxide poisoning that can happen when anesthesia machine is used for the first patient on Monday morning after being idle over the weekend due to chemical reaction between the volatile agent and the carbon dioxide absorber. So absorbent, right? So when an anesthesia machine is left unused for a long time, soda lime can become partially desiccated, leading to higher chance of producing carbon monoxide when a volatile is used. Okay? So regularly changing the carbon dioxide absorption, flushing the breathing circuit with such gas before the first patient on Monday, and monitoring for signs of carbon monoxide exposure are the methods of preventing a cacophony like this. What are all these things?
Newer absorbent.
Newer carbon dioxide absorbers. Okay? They are called spiralith and litholime. And they have been introduced to eliminate the drawbacks of your regular soda lime. So there is no sodium hydroxide or potassium hydroxide. So no formation of compound A or carbon monoxide. No heat production because no exothermic reaction. No dust or powder formation as they are more solid. And the above property also prevents channeling. And color change on exhaustion is permanent and easily visible. Okay? They don't regenerate. What is displayed here?
It's adult brain circuit.
Adult brain circuit. This is
Pediatric
brain circuit.
with face mask.
And the dimensions of brain circuit normal is 1.8. Whereas for MRI it is up to 5.4. It has a 22 millimeter outer corrugated tube and a 6 millimeter inner green PVC. What are the indications for use of pediatric brain circuit?
For controlled and spontaneous ventilation, sir.
It is used mainly in MRI suits and endoscopy procedures. What is this?
JR circuit, sir.
Jackson recycle. Okay. Lightweight, portable, no valves, no resistance. All the features you should be able to identify. These are all the older types of Jackson ray. What does the scalar picture show? What type of ventilation? What mode of ventilation it is showing? This is the
Spontaneous.
patient triggered spontaneous ventilation with the pressure limit. So this is a pressure support ventilation. So you must be prepared to have asked the questions on this various types of ventilation with the scalar. Okay. So what is automated weaning? So used
It
for
will
closed
support
loop
the breath
control.
of.
It can interpret clinical data in real time, gradually reduce pressure support and perform spontaneous breathing trial. And it reduces the requirement for clinician input in a weaning process and improves outcome. What is failed extubation?
The need of re-intubation after 48 hours of extubation.
Within 24 hours of extubation. If you require re-intubation, it is called failed intubation. Failed extubation. What is shown in this?
This morning.
This monitor, depth of anesthesia monitoring. What is entropy?
It also
Concept of abnormality in system. What are the types of entropy?
a state entropy and response
State
entropy.
and entropy, response entropy. The characteristics of each one, it should be
0 to
known.
91, 0 to 100.
So how to connect it, how to check it, all these things we will stick through. What is shown in the ultrasound image of the vertebra?
Tripod
Can
sign and
Ultrasound of spine.
Trident sign
these are all spine
showing transverse process.
And Hamel head sign.
Okay, so this is the
Horse head
all
sign.
these things is paramedian, sagittal, transverse view, articular process view, laminar view, and oblique view. All these are paramedian, sagittal, and there is one transverse interlaminar view. And this is a transverse process view is done for the presence of figure-like projection of transverse process, which is called the trident sign. You can see this is how the three prongs are coming. So this is called the trident sign. This is called the camel hump sign, which shows the vertebra being connected to the articular process. And this is called the sawtooth or horse head pattern, and that is to find out the interlaminar space. And this is a slight modification of the same thing to identify the thickness and the dural distance. And this is the transverse interlaminar to find out the tilting probe to find out the articular process and facet joints. So in which type of patients this sort of spine ultrasound is useful?
difficult spine,
Obesity and
Obese
Obese
patients
patient.
and patients who
Ankle
already had
spondyl-
some spine surgery, okay, where palpation of landmarks are difficult. Is this being done? The microlaryngeal surgery with high frequency jet ventilation. What is this equipment?
Jet ventilation.
This is called the Sanders jet
Sanders
ventilation.
jet.
So the principle of jet ventilation, Venturi effect, we should be able to say that. What are all the other applications of Venturi?
yeah.
Venturi mask.
It's used for oxygen delivery,
Nebulization.
venti mask, then Sanders jet ventilation. Nebulization also works on Venturi principle. Some modern vaporizers also use the Venturi. And what is shown here?
Manual defibrillator.
Manual
It is an external
external
defibrillator.
defibrillator.
What is a defibrillator?
It is the machine to correct to give the shock to deliver.
It is a device that applies electrical charge or current to the heart to restore the normal heart rhythm. What are the types of current applied?
Monophasic and biphasic.
Monophasic and biphasic. Why biphasic is preferred?
It is a less damage and the current is passing into the.
Correct.
Less energy.
What are the types of paddles used to, and where are they used?
And
It can be spoon paddles for
Pediatric.
internal fibrillation, handheld paddles for external, and adhesive pads used for automated external defibrillator. What are the indications and contraindications for defibrillation?
pulseless ventricular tachycardia and VF, ventricular fibrillation.
Contraindication, asystole and
Asystole,
PVF.
pulseless.
Cardio version. What
Cardio
condition
version.
that is
Synchronized. It is an elective and
refers to
synchronized
delivery of
R wave of
electrical
the
shock,
ECG.
the time at the peak of R wave on the EKG and revert to the normal sinusoid. It is an elective procedure done under GA, requires less energy than defibrillation. And it is hemodynamically unstable or faint pharmacological conversion of AF and AFP cluster. We usually do cardioversion. What are the positions for the placement of electrodes for external defibrillation?
Anterior lateral and anterior posterior.
And lateral.
Anterior, it is external and apical, anterior posterior and posterior right or left intrascapular. What are the components of a defibrillator?
Paddles, monitor, and
It's a power
Leads.
source, a capacitor, an inductor. They are arranged into a charging unit. Then there is a discharging circuit with a switch in between the charging and discharging unit. What is an automated electrical defibrillator? It's a portable medical device that analyzes the heart's rhythm and delivers an electric shock. This is
yeah.
Warmer.
Warmer.
Bear
Bear
hugger.
bear hugger, warmer or bear hugger. And all you should know how heat is lost in the OT and how can it be prevented. What is this?
Handheld
Handheld ultrasound
Handheld OSD.
applications for all these things: regional anesthesia, vascular access, first lung ultrasound, airway assessment. Mention the uses in neuro monitoring.
ICP monitoring, that optic nerve sheath
It
diameters.
can be used for optic nerve sheath diameter, transcranial Doppler, and pupillary light reflex monitor. It's simple.
Macintosh plate and larynx.
So the parts of all that in a hand, handle, hook, horizontal flange, vertical strap, and big tip and the tongue spatula. So these are all the various types shown here.
Yes.
What is this?
McCoy blade.
McCoy blade.
Noise. Very good.
Epiglottis.
Okay.
We have to lift the hip.
How are video laryngoscope classified?
Channeled and non-channeled.
There are different classifications of course. Non-channel and channel. Examples are all those things. Be prepared for that. And what is shown here?
Fiber optic.
Flexible fiber optic bronchoscope or videoscope. The parts of that should be able to say eyepiece, diopter ring for focusing, control lever, working channel, body, insertion cord, light source, and suction valve and port. Okay. So, working principle of fiber optic scope.
Total internal refraction.
Total internal reflection. Very good. So this is the working channel. What are all the uses? How it can be, how it is to be used. So this is micro-lateral surgery. This is rigid ventilation. What are all these things? They're all various intubating
Different
aids.
size of bougies, airway,
Various sizes of stillet. Then
Bougies.
you have different makes of bougies. Then you
And
have
airway
exchange catheters.
airway exchanger port, etc. Okay. And this is what is called the traffic light
color-coded.
So what is the purpose of this color-coded bougie?
How much length we have to go in the
so this
red
will
is
prevent too much of introduction of the bougie and damaging the carina at the lower part of the respiratory tract. So green is safe. Amber color is somewhat acceptable, but red zone
Red is
indicates that you are too deep inside.
Bronchial.
Okay, so that is how. These are
White
all
color.
Oral airways.
Oral airways.
Good eyes
Ah,
airway.
yes.
Nasopharyngeal
Nasopharyngeal
airways.
airways.
How to measure the size? You can know
Angle
all
of
that.
mandible.
This is
Oversipine
oversipine
airway.
airway
Open
for
airway.
Bowman.
Suction
Suction
catheter.
catheters.
color code for section. Control with the control knob tap. This is the anchor plastic
Younger
section.
plastic section.
What is this?
Closed
Loop suction.
Closed section.
suction catheter.
This is a PA catheter.
PA catheter.
Catheters.
This and ask you to identify. So name the parts. You should be what are all the three ports which are there. One is for thermistor port, another called CVT, third is the PA port. So the indications for that, why it is not commonly used nowadays? Because of complications like
Arrhythmia. Artery rupture.
these are all the various types of
This
masks.
masks, black rubber.
Rubber anatomical mask.
Tender
What is this?
One is for
Endoscope.
endoscopy.
This is endoscopic
Endoscopic.
mask for endoscopy. And what is this?
Bypass.
CPAP.
CPAP.
Mask for CPAP. This is a harness for holding the
And
mask in position.
Venturi mask.
These are all the bag, metal prongs, oxygen concentrator.
concentrator.
This is
Face
the
mask.
non-rebreathing mask. This you should be able to identify. What are all these
Spinal
things?
needles.
Spinal
Different
needles.
types of spinal needles. Color coded spinal needle. The tip, various names.
Quinky.
And this is a combination of what is this?
Combined
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 spinal
Spinal
epidural.
epidural set.
epidural set.
needle.
2 needles.
What is this?
This one is.
This is for post-op relief elastomeric infusion pump.
Oh,
Okay, so you
it is
fill
fine.
the whole bottle with the dilute solution of local anesthetic and connect it to the epidural catheter. It will deliver at whatever rate you are.
Local anesthetic.
What is this?
Bascam.
Which
Third
generation?
generation.
Third generation.
In the parts. Of course,
Suction.
it's a non-inflatable cup. Okay, so it all will fill up by itself and adjust. It has got a ventilating tube, it has a suction tube, and the person who designed this or the
Basca.
LMA, various classifications, the person who introduced, and then the generations, what is the difference between all this, so that all this you will be able to identify. The various types of tubes which are used.
Bronchial block.
They are all used for laser surgery.
Oh, it's
So
a
rush
laser surgery. Lush laser.
rod and Vivona.
Vivona.
So what to do when there is a airway fire and laser is being used? What are the 4 E's to be
Eliminate,
done?
evacuate,
Yeah.
and
Eliminate, evacuate,
Evacuate.
extinguish, and evaluate.
Extinguish and evaluate.
This is a very simple question that can be asked. What are the parts of a endotracheal
Endotracheal
tube?
tube.
Can you identify each one? What is A?
inflating.
Is the inflating
Valve.
It is a valve, inflating valve for air. What is B?
Inflating cuff.
This is a blue thing. What does it mean for that? When you inflate, how do you know that this cup is got inflated? This
by
portion
checking
only
with the-
checking
swells up, you know.
Oh, sorry.
Yes, sir.
What is this portion called? It's called the pilot balloon.
Pilot balloon.
Any name for that pilot balloon? It's called Langton-Hewers pilot balloon. Okay, LANGTO, Langton-Hewers pilot balloon. And what is this C?
Connector, universal connector.
Universal connector. So this is attached to that. And what is H is the
Cuff.
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 What is this black line called?
The vocal cord, presence of the vocal cord.
It's called
It
vocal
crosses
cord guard.
Guard.
Okay, you are not supposed to push the tube beyond this into the vocal cord. So this is called vocal cord guard. And what is this I?
Murphy's eye.
Murphy's eye is
Sorry,
J.
sorry.
J.
This is the
I
bevel
see.
end.
end.
Bevel.
Bevel
So
end.
these are the G is the tube. F is the
Markings.
curvature. What is the radius of angulation of this tube? What is called? What is the name for that?
Megill's curve.
Michel's curvature. What is the angle? So this is Michel's curve of radiature, 140 millimeters. Okay, so this is the bevel. This is the Murphy side. This is the cuff. This is the vocal cord guide. This is the radio marker line. This is the PVC tubing. This is the pilot balloon. Langton Hoover pilot balloon. This is the spring loaded one way valve. And this is the 15 millimeter adapter. Okay. These are all the various parts of tracheostomy tube.
Tracheostomy tube.
Indications for tracheostomy.
Mhm.
What is this?
Video line.
Videos.
Yeah.
Video.
Laryngoscopy.
Video assisted LMA.
Total track video laryngeal mask. No, this is actually a laryngeal mask with a video laryngoscope. This is called the Bonfield intubating stillet. And what are these?
Magill's forceps.
Magill's QC or border process for use with video laryngoscope. This is the Magill's. But this one is for the use with laryngoscope. This is standard Magill's forceps. Okay, so this one is the Magill's forceps. This is called the Suji
Bodeker's
forceps
forceps.
for use with video laryngoscope to guide the tube inside the larynx. Okay. What is this?
Double lumen tube.
Double lumen tube. Very good. Indications, all that you know. This is a pediatric tube. Double lumen. Maros Billum. And this is the bronchus blocker, easy blocker. Airway agents. What are these things? What is this tube?
It is a
What is this particular tube?
It is for tear-shaped.
It's the Oxford tube.
Oxford
Okay?
red rubber.
This is the preform tube. This is the oral tray tube. This is the Oxford tube. All used for oral surgery. What is this?
Red rubber tube.
Red
Red
rubber
rubber,
tube.
plain rubber tube, nasal tube. And this is red rubber oral cuff tube.
Oral tube.
Okay. And this one is,
North Pole.
this is called Montandol tube, used for tracheostomy. In total laryngectomy, they used to use this. These are all various metal connectors. Just for historical sake, this is anchor
Suction.
sterile anchor suction. This is closed suction.
Closed suction.
This is the IV section.
IV fluid.
IV set.
So this is the,
PNS.
what is
Peripheral
this?
nerve stimulator.
Peripheral nerve
Peripheral nerve
stimulator.
stimulator. Various functions
This is
of
for
that.
energy function.
So these are all the equipment. This is
Pulse oximeter.
pulse
Finger probe.
oximeter with a finger probe. What is the purpose of this PVA? That is index control circulation index. What is Massimo technology? It's an American company name. Non-invasive monitoring equipment. And it uses what is called the signal extraction technology.
ICD.
ICD, types, and 1 bottle, 2 bottle, 3 bottle systems, uses and its what is safe triangle, the limit rating is
Anterior of
safe.
pectoralis major.
Pectoralis major,
latissimus
latissimus
dorsi,
dorsi,
apex of the nipple
axilla.
and
Very
axilla.
good. So this
15
is the
to
modern
16.
drainage system that we use. All the bottle system is gone. Now we have this disposable drainage system. What is shown here?
Arterial line.
Arterial line connection. Okay? It's an intra-invasive arterial line connection. The components are cannula, fluid fill tubing, transfusion, etc. Superior analysis, how it is done. for this damping and resonance, you should be able to say. And what are all the factors which can affect the reading? Three-way taps, bubble clots, vasospasm. And why should pressure transducer be positioned at the same level of the patient's heart?
To avoid the
Measure the
errors.
correctly, avoiding error caused by change in hydrostatic pressure of the fluid column. Okay. What is this?
Cardiopulmonary circuit.
This is the cardiopulmonary bypass machine. These are all the components. So all these things, oil, ultrasonic flow, all that we have to. Okay. So that is just an overview of all the machines and equipments that can be asked in the examination. So that is a very rapid. For lack of time, I can't go beyond this.
Sir, I just wanted to ask that is there any specific difference for entropy and this BIS monitoring?
This monitoring. No, each one has got its own advantages and disadvantages. Entropy monitoring, because it finds out the resting condition also. Whereas BIS starts from analyzing your ECG right from awake state to the anesthetized state.
Okay.
Whereas entropy monitoring has a different value. All are nothing but methods of identifying the depth of anesthesia.
Yes.
So entropy is not very commonly used because it is little more cumbersome compared to the BIS monitoring. But some people feel that entropy is more accurate than BIS.
Thanks.
So all of you got your center postings?
Yes, sir.
Exam center? Very good. Wish you all the best.
Thank you, sir.
Thank you, sir.
Hope you all do well and maintain the success rate of 10% result like the previous years. Wish you all good luck. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, dear students. Wish you all the best. You all do well in your exams.
Thank you, sir.
Thank you. I'll sign off.
Yeah,
Thank you.
we'll sign off.